this is health journalism is true empowerment of people, and I'm very passionate about health journalism because these are the journalists who make the public keep their health up.
This is not something that has happened just today or yesterday. This is a work of almost 9 years when we started Health Writers Association called HEAL, where we brought all journalists covering health together on a platform to share their problems and to share their ideas and to share how the future road is all about.
To conduct such conferences to improve healthcare system with the help of media persons, because it is just not the doctors or the practitioners or the specialists or super specialists who are responsible for the healthcare, but more than that, it is the media people who take the right viewpoint to the public.
I really appreciate this convention that is happening here in Goa, which is a conglomerate of 90 leading health writers from the country, where we get to talk to the media and tell them about correct health, wellness, nutrition, and they get an aspect of the correct thing and know how to report responsibly.
This is the third time that I am attending HEAL Foundation's Health Writers Convention, and I have found that every year by year, my horizons have really broadened with my participation over here. We have got to learn a lot here, and the sessions this time have been really extremely helpful.
I promise that whenever there is a meeting like this anywhere in the country at any time in the future, I will certainly love to join that meeting. I have to convey all my heartiest greetings, congratulations, thank you for all the support that senior and new health journalists, essayists, authors, everyone is giving to the cause of health in this country.
Check, 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 check. Check, 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 check. Hello. Hello.
is a tremendous conference. This is health journalism is true empowerment of people, and I'm very passionate about health journalism because these are the journalists who make the public keep their health up.
This is not something that has happened just today or yesterday. This is a work of almost 9 years when we started Health Writers Association called HEAL, where we brought all journalists covering health together on a platform to share their problems and to share their ideas and to share how the future road is all about.
To conduct such conferences to improve healthcare system with the help of media persons, because it is just not the doctors or the practitioners or the specialists or super specialists who are responsible for the healthcare, but more than that, it is the media people who take the right viewpoint to the public.
I really appreciate this convention that is happening here in Goa, which is a conglomerate of 90 leading health writers from the country, where we get to talk to the media and tell them about correct health, wellness, nutrition, and they get an aspect of the correct thing and know how to report responsibly.
Check
This is the
1
third
2.
time that I am attending HEAL Foundation's Health Writers Convention. And I have found that every year by year, my horizons have really broadened with my participation over here. We have got to learn a lot here, and the sessions this time have been really extremely helpful.
I promise that whenever there is a meeting like this anywhere in the country at any time in the future, I will certainly love to join that meeting. I have to convey all my heartiest greetings, congratulations, thank you for all the support that senior and new health journalists, essayists, authors, everyone is giving to the cause of health in this country.
think this is a tremendous conference. This is health journalism is true empowerment of people, and I'm very passionate about health journalism because these are the journalists who make the public keep their health up.
This is not something that has happened just today or yesterday. This is a work of almost 9 years when we started Health Writers Association called HEAL, where we brought all journalists covering health together on a platform to share their problems and to share their ideas and to share how the future road is all about.
To conduct such conferences to improve healthcare system with the help of media persons, because it is just not the doctors or the practitioners or the specialists or super specialists who are responsible for the healthcare, but more than that, it is the media people who take the right viewpoint to the public.
I really appreciate this convention that is happening here in Goa, which is a conglomerate of 90 leading health writers from the country, where we get to talk to the media and tell them about correct health, wellness, nutrition, and they get an aspect of the correct thing and know how to report responsibly.
This is the third time that I am attending HEAL Foundation's Health Writers Convention. And I have found that every year by year, my horizons have really broadened with my participation over here. We have got to learn a lot here, and the sessions this time have been really extremely helpful.
I promise that whenever there is a meeting like this anywhere in the country at any time in the future, I will certainly love to join that meeting. I have to convey all my heartiest greetings, congratulations, thank you for all the support that senior and new health journalists, essayists, authors, everyone is giving to the cause of health in this country.
This is health journalism is true empowerment of people, and I'm very passionate about health journalism because these are the journalists who make the public keep their health up.
This is not something that has happened just today or yesterday. This is a work of almost 9 years when we started Health Writers Association called HEAL, where we brought all journalists covering health together on a platform to share their problems and to share their ideas and to share how the future road is all about.
To conduct such conferences to improve healthcare system with the help of media persons, because it is just not the doctors or the practitioners or the specialists or super specialists who are responsible for the healthcare, but more than that, it is the media people who take the right viewpoint to the public.
I really appreciate this convention that is happening here in Goa, which is a conglomerate of 90 leading health writers from the country, where we get to talk to the media and tell them about correct health, wellness, nutrition, and they get an aspect of the correct thing and know how to report responsibly.
This is the third time that I am attending HEAL Foundation's Health Writers Convention. And I have found that every year by year, my horizons have really broadened with my participation over here. We have got to learn a lot here, and the sessions this time have been really extremely helpful.
I promise that whenever there is a meeting like this anywhere in the country at any time in the future, I will certainly love to join that meeting. I have to convey all my heartiest greetings, congratulations, thank you for all the support that senior and new health journalists, essayists, authors, everyone is giving to the cause of health in this country.
This is a tremendous conference. This is health journalism is true empowerment of people, and I'm very passionate about health journalism because these are the journalists who make the public keep their health up.
This is not something that has happened just today or yesterday. This is a work of almost 9 years when we started Health Writers Association called HEAL, where we brought all journalists covering health together on a platform to share their problems and to share their ideas and to share how the future road is out.
Good afternoon, everyone. Ladies and gentlemen, distinguished guests, and dear colleagues, in the realm of health communication, welcome to 8th National Health Writers and Influencers Convention 2024. As we gather here, we embark on a journey fueled by passion, driven by innovation, and united by a common mission to harness the power of words and influence for betterment of health and well-being worldwide. Allow me to begin our proceedings with a quote from legendary journalist and author Norman Cousins, who once said, "The capacity to care is the thing which gives life its deepest significance." Indeed, as health communicators, we are endowed with the profound responsibility of caring, of giving voice to silent struggles, and of championing the triumphs in the realm of health and wellness. In the words of renowned journalist and physician Atul Gawande, better is possible. It does not take genius, but it takes diligence, moral clarity, ingenuity, and above all, it takes a willingness to try. As we convene here today, let us embody this spirit of relentless pursuit of excellence in our craft, pushing the boundaries of what is possible to elevate the discourse and drive meaningful change. Throughout today and tomorrow, we will delve deep into the currents shaping the landscape of health communication. From the eloquent wisdom of Florence Nightingale, who proclaimed, rather 10 times, die in the surf, heralding the way to new world, than stand idly on the shore, to the timeless insight of Maya Angelou, who reminded us that when we know better, we do better. Our agenda is enriched by the profound wisdom of those who came before us, guiding our path forward with clarity and purpose. But beyond the sessions and workshops, this convention serves as a testament to the power of community. It's a gathering of minds, hearts, and spirits committed to a shared vision of a healthier and more informed world. It is a celebration of the tireless work, dedication, and creativity that each one of you puts on the table every single day. So let's embrace the opportunity that lie ahead. Let's engage in meaningful dialogue. Let us forge connection that will inspire collaboration and spark change. Once again, welcome to all of you in 8th National Health Writers and Influencers Convention. Now to start today's program, I will extend a warm invitation to Mr. R. Shankar, President HEAL Foundation, Dr. K.P. Kochar, Professor and Head Department of Physiology, AIIMS, New Delhi, Dr. Swadeep Srivastava, Founder and Chairman, HEAL Foundation, Dr. Chandrakant S. Pandav, former HOD, AIIMS Community Medicine, Shri Rajiv Tikkuji, Dr. Sanjay Mattu, Dr. Vivek Hada, and Dr. Rupak Singla sir, to please join us on stage to light the lamp and start today's program. If all of you can please come on the stage, please. I would also request Mr. Manish Rastogi and Mr. Rohit Singh to please join us for this ceremony. The wisdom, leadership, and commitment of these visionaries in the field of health and health communication serve as an inspiration to all of us, and we are deeply honored to have you initiate our journey together.
सरस्वती महाभद्रा महामाया
Thank you. I would request Mr. R. Shankar, Dr. Kochar, and Dr. Swadeep to please come on the dais. Now I would request Shankar sir to please come on the podium and give us welcome address from HEAL Foundation. Sir.
Respected senior doctors, members from the media, ladies and gentlemen. This is the 8th national workshop that we are holding, HEAL is holding, and it has been a journey of 25 years. Actually, this should have been the 10th workshop, but in between we had the pandemic coming in, and so we couldn't hold the conventions. But speaking of the pandemic, I think we need to pay respect, our due respects to senior doctors, to caregivers, to paramedical staff who fought the virus and laid their lives down. We also need to pay respects to senior journalists, photographers, members from the TV crew who looked into the eye of the virus and reported from front line and laid their lives down. I think it is because of them that we are here today. Now, pandemic is gone, hopefully. We are now in the cusp of a new era. Like the pandemic, when it came, a lot of us didn't know what it was going to do, and what is the future. Just like that, we are now, as I said, in the cusp of a new era called the artificial intelligence and AGI, where we do not know what is to be done, what the future would be. Would we lose our jobs, or we have to adapt? But you know, if you look at history, when the wheel was first invented, it was predicted that half the humanity would die because we would be crushed under the wheel. When the steam engine was invented, there was a great cry in Britain that more than half the cattle population would die because they would be afraid of the sound. When AIDS came, serial researchers said half the population of this world would be wiped out. Then when we transitioned from the 20th century to the 21st century, when the 1990s and we went to the 20s, there are a lot of predictions that our bank accounts would be wiped out because computers would not know how to go from 19 to 20. Telecommunication networks would break down, and that there would be chaos in this world. But then what happened? We are so special that we know how to adapt, and hence we need not fear artificial intelligence or AGI. The only mantra to this is we should know how to adopt ourselves. That said, we have all grown older and wiser, and we have grown older, but some people still remain young. The new generation is supposed to take over. And as we progress, I was asked what's the situation of health media or health writing in today's world. A quick analysis showed that news reporting on health occupies just about 1% in a newspaper, or less than 1%. But that's not a fair assessment, because when you look at a whole newspaper, you have sections like the business, like sports and entertainment, which are independent verticals by themselves. But health has to compete with the main section. And so when you look at the main sections, then the health coverage should be slightly, say, above 1%, 1.5%, but nothing much to claim of. But I'm sure in the future what would happen is that we would have an AI application which will tell you when you should write your health stories, how and where, and how you should place it. I think that's the era that is supposed to come. But I'll not take the speech long, but as the president of HEAL, it is my great desire that we increase our footprints across India much in a larger perspective. And I would request Swadeep that the next convention should be held in Northeast, where we neglect the community, where we are not seen. So if we have to bring them also into the mainstream reporting so that we know what's happening there. Last but not the least, before I conclude, I'm always reminded of the Buddha. If you look at the Buddha, many of us, of course, most of us have not seen him, but the statue of Buddha, when you see, you will find that Buddha had a very broad head. He thinks. That's what doctors do. They think through prescriptions, they think through procedures, and they think how to heal. That's what good journalists do. They think through a story. They think how exactly to present it. The Buddha had a long nose. Good doctors, sniff for all details before they come to a conclusion. Journalists sniff for data, for information, and that's how they become good journalists. And the Buddha had long, large ears. Good doctors listen to what's happening in the world around them, to the research that's happening around them. Good journalists listen to what's around them and to report factually what's correct. But the Buddha, strangely, had very small lips because whatever he spoke sense. That's what doctors do. Good doctors speak sense. Good journalists speak sense. So to all the aspiring Buddhas over here and to all the Buddhas over here, be like the Buddha so that you know how your future is going to be. Thank you very much.
Thank you, sir. Now we'd request Dr. Professor K.P. Kochhar, Professor and Head Department of Physiology, AIIMS, New Delhi. She will talk about bridging the gap between doctors and media for effective and impactful health information. Ma'am, please.
So a very warm welcome to all of you, our friends, and greetings from AIIMS too. And thanks Dr. Srivastava and Mr. Shankar for giving me this opportunity to try to cross the gap between medicos and media. So sir just mentioned some very nice things about a good doctor and a good journalist. And sir, I would like to submit to take it a step further. Doctors are good, journalists are also good. We should try and strive how to have better doctors and better journalists. So to introduce to what we do here at AIIMS, start from our ancient wisdom. So sir, from what you said, it is very important in today's age where data is a big resource, and we all know how we go from data to information, which is called processed data, and then from information to knowledge, which is how the journalism ecosystem and the health ecosystem has evolved. And then the most important thing is to, as poet T.S. Eliot had said, we should not lose what we have gained in knowledge to our wisdom. So wisdom, sir, as Buddha, is the ultimate. And this is also showing us our ancient wisdom of medical healing. So when we talk of healing or health, we think of not having disease, or the classical WHO definition of health, where till some decades back the spiritual well-being was also a part of it, but somehow we lost it because people thought of spirituality as just one dimension or one domain of institutionalized religious rituals or practices. Whereas to people like us, I'll introduce you to what we are. I am an MD, MBBS MD in physiology, and then I did a PhD because we have a lingo that जो एम से PhD कर लेता है वो दुनिया में कुछ भी हासिल कर लेता है. Plus, sir, we wanted to have a body of clinical scientists so that we can traverse the domains of healthcare on one side and what is occurring at the bench. So the bench to bedside, navigating that trajectory is also important for us. And I believe in our collaborations in future, how we can help you is by making you more informed about not just clinical practice, but also the base of the pyramid, which is basic science. And then we come to translational science. So physiology is about how our normal body works, which means not only our health, but also our wellness. We could call it absence of disease or infirmity. But a step more than that, that is our fitness and well-being in the domains of physical, mental, emotional, social, financial, and spiritual. So, apart from that, we have had the presidency of G20 a few months back. We had a big event. People came to India from different countries and different cultures, and they knew what we are. So in these domains, our environmental consciousness, our interpersonal skills, and our interpersonal health, whether it be in the family, whether it be in our workspace, or whether it be in our relationships or our dialogues with the patient, and more importantly than the patient, the caregiver families of the patients. Okay? Keeping in mind intact our intellectual knowledge as well as our wisdom. So this is important to know what are the elements of health and well-being and the determinants. In physiology, we have basically 4 domains. One is nutrition, how much to eat, when to eat, how less to eat, how the body assimilates our food into our mind and our muscles and our storage tissues. The second is sleep. How much to sleep, how much is more, how much is less, what is hypersomnia, what is hyposomnia. Okay, and 2, basically physiology is about resource optimization. Okay. The third is how much to exercise, how less, what type of exercise, for what age. So, and the last one is stress management. If we take care of these 4 domains, our nutrition, our sleep, our exercise, and our stress management, then we can do what we call physiological prescriptions for good health and well-being rather than pharmacological. And second, if we can address the gap between our traditional systems, scientifically validate them and present it to the modern world to convince them that what we had, sir, 7,000 years back is not mumbo jumbo. And the normal modern medicine, which is just about 350 years old, with the Industrial Revolution and the Renaissance, we can work on that and teach them, because now they are coming to us. No, the standard textbooks are giving about a 72 kg Caucasian Western male, but we have our own cultures, we have our own body mass composition analysis, we have our own kind of wisdom, we have a different set of cognitive abilities, and physiologists therefore form the base and जो हमारे senior Dr. Deepak, my ex-head in our department, used to say, हम consultants के भी consultants हैं, plus we are free from heavy duties in ICUs and intensive care, emergency medicine and the like, to be able to tinker in our creativity and perform the fourth domain of our duty or mandate, the three domains being teaching, research and clinical service, by which mandate AIMS was established, and the fourth is our social responsibility, reaching out to the public, popularization of science, informing, and that is where we want to join hands with the media. Because this was from Voltaire, many ages back. Doctors are men who prescribe medicines for which they know little, for diseases about which they understand even less, for people about whom they know nothing. In Lancet it was, what does he of medicine know, who only medicine knows. So we have established AIMS Medical Humanities Initiative here, where we sensitize our students to understand diversity tolerance, destigmatization, cultural contexts of the patient, medical ethics, medical professionalism, how to be personable, how to care for the dignity of the dying. The outcomes we may not be able to change, but the processes we may be able to change. So every case has its lesson and learnings. So how do we redeem the paradigms lost in medicine today and blend compassion with competence, as Sir alluded to, advances in technology, healthcare economics, especially when our country is on the cusp from going to a developing to a developed country maybe in the next 26 years, public awareness of healthcare issues, patients, advocacy groups, media, how we link with them, and then the societal erosion which we have had. No, financial pain is a very important component of palliative care which we teach to our students. Greed, arrogance, deception and coercion. Transfer of decision making or a participative approach instead of a top-down prescriptive approach. So the best blend would be good science, good knowledge about our country and its cultures and our uniqueness, and then have a high-touch performance to mix the science and the arts. That is why humanities is so very important, and we want media friends to teach us, and we learn from you how to not lose track of the humanities. Okay? So Hippocratic Oath, we all have studied, but we also have our students who are, during their convocation, they take the oath of AIMS Charak Shapath. Okay? But having said that, today I was interacting with the media persons. Why is only a doctor published for criminal negligence? Why not a lawyer who loses a case for a patient? Why not a teacher whose student fails? Why not an accountant who hasn't filed the tax returns in time? Why not an engineer who makes a bridge? So we are all contributors to society. We are all, as I said, good people. Please be kind. Please be compassionate to other professions also. Don't expect the sky from doctors. They are humans. This is a slide from the Valley of Flowers. So, medicine is a pilgrim's progress, the journey. A young student, 16, 17 years old, who has been taught to avoid the dead and the dying and the deviant, and who has been told to shun excreta and urine and stools and body fluids, and to stay away from, SAT. In 60s movies, they showed that anybody who's having a mental disorder would be stoned, right? But today, we want to mainstream them, we want to destigmatize them, okay? So anybody who's having any kind of a physical, mental or emotional disorder, or जिसको हम बोलते हैं आजमाइश का समय है कुछ time के लिए, we have to be kind and compassionate to them, whether it be our colleague, whether it be anybody in society, our neighbor, and whether it be a doctor who has not had food for maybe 36 hours and is still taking care of the patient. So sir, we would like that we would be informing the media about which are the genuine situations. Okay, a car accident happens because the person hasn't, eaten or slept. And believe me, you can search it. Driving under influence of any substance doesn't have as many accidents as lack of sleep. So we have to be kind to our truck drivers who are driving on the highways across time zones, even though we have one time in India. Okay, so night driving is the single most important culprit for accidents. And then we have media reports, ronda gaya, kuchla gaya. Today also we know a motorcycle boy hitting a truck. ठीक है, अब ट्रक वाले को कंपनसेशन देना है. क्यों देना है? क्योंकि उसकी गाड़ी का मास इनटू वेलोसिटी, मोमेंटम इतना ज़्यादा है कि छोटा व्हीकल हमेशा उसको चोट पड़ेगी. वन डे अ टैक्सी ड्राइवर टोल्ड मी कि मैडम उधर एक्सीडेंट हुआ है, मर्सिडीज और ऑल्टो का. अब मर्सिडीज वाले को मार देंगे. Why? Because they will not forgive him for owning a more expensive car. That is the way, irrespective of the fact that somebody is crossing the road, not obeying the rules. So these are the type of things, and they are also in the medical ecosystem. If the patient doesn't follow the advice of prescription, who is monitoring that? Who is validating that? And if there arises a complication, then doctor is to blame. So these are the type of things which we want, so that we have a win-win situation. Okay? These are some of the things which a medical student undergoes. And therefore, healing ethos, physicians, we will do our duty to heal ourselves and the society. And in the process of healing them, we get healed ourselves also. But the social contract between the medical profession and the society is professionalism, expectations, obligations. But having said that, the interactions with patients, a very important part of the doctor-patient relationship is the media reporting. So if media projects us as good people, we can become better. If media projects us कि हम बुरे लोग हैं, ठीक है? अगर कोई बाथरूम स्लीपर में आ गया, इमरजेंसी पेशेंट में हमारा डॉक्टर, और वो बात कर रहा है फोन पर, why do the people think कि वो गर्लफ्रेंड से बात कर रहा है या मस्ती कर रहा है? For all that matters, वो अपने कंसल्टेंट से सलाह ले रहा होगा इसको कैसे हैंडल करना है, और वो सोचेंगे पेशेंट को देख नहीं रहा, फोन पर खड़ा है. So these are the type of things which we, sir, and this is just the beginning today. There are many such situations, and I feel you should, just like we have a jury for today's evening function, we should have a jury where some of us can tell us, so even a media reporter should talk to some kind of specialist in that field before reporting the outcome, because we don't want to kill anybody. No, our destinies are intertwined, the patient and the doctor, right? A bad outcome hurts the doctor also as much as it would hurt the patient and the family. And having said that, to become a best doctor or a surgeon, हमको अपनी इज्जत खुद करानी है. I remember my husband is a surgeon. We were invited somebody for dinner, and that man, he was an elder man, maybe 25 years senior to me. He said, madam, why I have invited you for dinner? I said, my husband did a good surgery. He says, no, your husband was the only one who said surgery is not needed for you. So that is the type of people we want as an ideal situation. So emotional literacy, empathy training, to understand कि ये कितनी मुश्किल से आया है हमारे पास traverse करके, that is more important. I welcome faculty of my department for solidarity and support. Yeah. So this is important, and therefore when we say prayers to our patient, right? So we are all very small drops in the whole space domain of the universe, and we are very small Shanbhangur drops in the time domain of the universe. Let us all do our duties. A doctor prays as much for his patient, and I've been here for 40 years, and I know the ecosystem, how hard the doctors work, but I want that if media reports good things about doctor-patient relationship, it will cause a salutary effect on the health ecosystem of the country and also health economics. And also, in DST, Department of Science and Technology, which comes under the Ministry of Science and Technology, one of the secretaries, Dr. Ashutosh Sharma, he started that every researcher should write and will give an incentive for writing something for popular article. कि आप अपनी साइंस को जैसे तद्भव से हम तत्सम करते हैं, कलिष्ठ भाषा में नहीं, लेकिन easy भाषा में कुछ articles करें. So sir, we have a whole army here of people who want to write, and if we join hands, a medical journalist and a doctor, especially from the what called preclinical branches who have time on their hands and who are good at writing publications, we will improve the health system of our country. Thank you very much.
Thank you, ma'am. Thank you, ma'am. The future is definitely the holistic healthcare, and our media friends will definitely need to write more about the doctor-patient relationship in the positive light. So now next, I will request for the intro, the perspective setting by Dr. Swadeep Srivastava. Can I have the video, please?
Namaskar, I am Dr. Swadeep Srivastava, representing HEAL Foundation and the HEAL Health Group. Today it is my privilege to host all the real storytellers of the country at this largest 8th National Health Writers and Influencers Convention, and we also have the privilege to host you at the most prestigious institute in healthcare, that is at AIIMS, All India Institute of Medical Sciences, New Delhi. So I would like to start with a small introduction of our journey, which we started 20 years back to give a shape to storytelling in healthcare in the form of Health Writers Engagement Program, wherein we created a platform of HEAL Foundation. I remember about 2 decades back when we started this journey, and the idea was to create a healthcare information ecosystem in the country which is more responsible, which is more effective. And for that, one of the most important stakeholders we all realize were the health media, health writers, who are today now they're in the form of new age media influencers too. And we started this journey about 2 decades back with HEAL Foundation program called Health Essayists and Authors League to train and to do the capacity building of health media of the country. And we have traveled a long journey from starting with 1 workshop to about 400 workshops what we have done with health media, and 7 national conventions which we are very proud of conducting successfully, engaging and training and sensitizing and motivating about more than 1,000 health media in this journey of 2 decades, and engaging with more than 300 key opinion leaders, experts from all sort of specialties and expertise in healthcare.
that whenever there is a meeting like this anywhere in the country at any time in the future, I will certainly love to join that meeting. I have to convey all my heartiest greetings, congratulations, thank you for all the support that senior and new health journalists, essayists, authors, everyone is giving to the cause of health in this country.
So the key objective of this program has always been to make health education, patient education more responsible, more effective, more accurate. And as we all know, in India, there is a need to change the conversation from let me fix you when you are broken to let me help you live a more active and healthier lifestyle. To achieve this objective, it was very important to engage with the media, with the stakeholders, and to communicate to the public a lot of health information which empowers them, which makes them more prepared to counter their healthcare. As you know, the burden of healthcare in India, we are always in short of the doctors, healthcare professionals, nurses, short of beds. To achieve the objective of healthcare for all and to make India the healthcare capital of the world by 2047, the biggest challenge lies in the healthcare burden what we are facing because of this lack of facilities, the disease burden growing every day, and the lack of healthcare professionals and the treatment options. So the answer lies in the preventive mechanism and how we can prevent ourselves from all preventable diseases like non-communicable disease, most common being diabetes, hypertension, to all other sort of cancer, respiratory disease, a lot of other preventable diseases. And to make Indians healthy, the role of information, that is the education, is the foremost. That's what we call information therapy, which is an integral part of all therapies what we provide in healthcare, which has also been a neglected part till now. That's why at HEAL Foundation today, also in association with AIIMS and all other partners from a prestigious institute like AIIMS to Association of Healthcare Providers of India to International Institute of Health Research and Management to National Accreditation Board of Hospitals and all other knowledge partners and supporters. The objective today is to bring information therapy at the forefront. That's why we have gathered together with approximately 75 to 100 top health media journalists, reporters, editors, and most importantly the new age media, the healthcare influencers, the YouTubers, the Insta influencers. Together we brought them at this August gathering at such a novel place of innovation and research at AIIMS, so that today we deliberate and we discuss on various healthcare issues, the trends, and take the onus on us as healthcare communicators, as healthcare awareness experts, and as healthcare media and influencers. The onus on us lies in propagating more and effective and responsible health awareness, making our patients, the caregivers and the society more informed, better informed, and to which ultimately would lead to healthier people and healthier India. With this objective, which is we start this convention and hope that for these 2 days we'll have a very invigorating sessions, very interesting discussions, lot of scientific issues coming up and being debated and discussed. The format what we have followed for the more than 2 decades has always been inclusive format of in the form of a workshop, in the form of discussions. So please feel free to raise questions, to get answers to your queries, and to clarify as much of your doubts and knowledge through all the top experts, key opinion leaders, and distinguished healthcare professionals who have come all the way today to address you, to meet you, and to interact with you. We hope that you'll have a wonderful time with us for these 2 days, and you'll go back from here more well-informed, more empowered in terms of your own knowledge and your own wisdom in terms of creating the right kind of awareness, education in the society with the power of your pen And that's what the objective is we want to achieve. All the best to you. Thank you.
So, Dr. Renu Bhatia, Professor Renu Bhatia, she is in charge of pain management clinic in our department. And as I said, physiology is doing a lot of things. I think we are the department who's collaborating maximum with neurology, endocrinology, medicine, psychology in a very, very big way, psychiatry, and also oncology. Dr. Nasreen, she's in charge of sleep management. Dr. Akanksha, she's working on biofeedback. Some of our elder faculty, senior faculty, Dr. Ratna Sharma, who is doing a whole lot of things using EEG, and Dr. Simran, they couldn't be here. Dr. Smita Patil, who's working on pollution and its effect, is working with the student elections. Then we have people like Dr. Ashok, who is in intraoperative neuromonitoring. Sir, ये आपको जानना चाहिए कि हम क्या करते हैं कि एनेस्थेटिस्ट जो है वो तो दवाइयाँ देखता है जब ऑपरेशन हो रहा है और सर्जन अपना काम करता है, लेकिन फिजियोलॉजिस्ट वहाँ पर खड़ा होके इलेक्ट्रोफिजियोलॉजी से ये देखता है कि सर्जरी के वक्त कोई नस ना कट जाए, कोई यूरेटर में डिस्टर्बेंस ना हो जाए, कोई स्फिंक्टर ना खराब हो जाए, कोई लैंग्वेज एरिया, क्योंकि लाइव सर्जरी करते हैं लोकल एनेस्थीसिया में एपिलेप्सी वगैरह के लिए, तो वो म्यूजिक एबिलिटी, उसकी स्पीच एबिलिटी प्रिजर्व्ड रहे. These are some of the things we do. Apart from what you know, Yoga and Integral Health and Wellness, Dr. Rajkumar Yadav, वो अभी जम्मू में हैं. So we have a very rich faculty, and each one of you will be able to help you. करोगे ना? For articles for public media. Thank you, sir.
Thank you, ma'am. Thank you. Thank you so much. Good afternoon, everyone.
And Dr. Suman Jain, I'm sorry I missed it. She is doing neuromodulation and nanomedicine and magnetotherapy here. Okay, we are also doing probiotic base. So जितनी भी diet के components हैं, spices, probiotic course cereals, हम सब करते हैं. Nutrition भी करते हैं और मशीनों से mind को करते हैं. So machines and machine learning हमारा topic है.
Thank you. Thank you. And so we'll start with the next session. Just 2-3 points to make. First of all, heartiest thanks to Dr. K.P. Kocher and the Department of Physiology team for facilitating us to organize this program, this convention, the 8th edition at AIIMS. This was my dream. As on the lighter side, what Dr. Kocher said, कि AIIMS से अगर PhD नहीं किया तो क्या किया? तो मैं AIIMS से तो PhD नहीं कर पाया. तो मैंने कहा AIIMS में हम अपना कॉन्फ्रेंस क्यों नहीं करते? So with this lighter note, we start this conference. We start with the next session. Just to bring into a couple of points to update you. We have till now in this journey of almost 2 decades touched base with about 1,500 health journalists, health writers from across the country in about more than 30 cities. We have touched base with them. We have trained them. We have done workshop as doctors do CMEs for their doctors. This is the first model in the world where you train the health journalists for health writing. So we have traveled almost 2 decades to touch and train about 1,500 journalists on all languages, almost more than 8 languages, almost more than 10 languages, including all English, all vernacular languages. We have engaged more than 500 experts, key opinion leaders, all over from the Ministry of Health to all the leading institutes like AIIMS, to all the leading hospitals, from the research institutes like NIN, and all sort of health experts, public health experts, medical experts. Almost 500 of them have spared time to come in our workshops and 7 national conventions to train these journalists on latest issues, latest trends. We have done very dedicated sessions on health writing, on how to interpret data, anthropology, public health. And this time today, we are also doing a very interesting session on AI in health writing. It's a friend or a foe. So that is very interesting because now where health writing is moving and how AI is going to impact and support health writing is something we are discussing in one of the session. And the last point is we have done so many programs with health writers, including health writers. After COVID, what we learned, there's a new age media called health influencers. They are the YouTubers, they are the Insta influencers, and we did a lot of research and reached out to almost 35 of them, and fortunate to have I think 12 of the top India's health influencers, the doctor influencers, the nutritionist influencers amongst us. So please give a big hand for them. They are the people who have following of more than 1 million, few lakhs, and their outreach is big. And so this is the first amalgamation merger of the traditional media, all the top media of the country what we have today. They are representatives in health writing, and the new age media. So both of them are going to learn, and that is the future, the synergy of these two media to create a better outreach and better impact in the society through the right kind of health information. Thank you so much.
Thank you, Dr. Swadeep. So without further ado, I would like to introduce our first session of the day, and I request all of you, I know, after lunch it's a bit sleepy, but we also have quizzes for you, so be attentive in the sessions, because we are giving 5 lucky winners the smartwatches tomorrow based on the quizzes that you would be answering. So for the first session, we have Turning the Tide on Tuberculosis, Innovations, Challenges and Collaboration Solutions. For this, I would like to request Dr. Sanjay Kembattu, Additional Deputy Director General, Central TB Division, NTP. So please join us on the dais. Dr. Professor Rupak Singla, HOD of TB and Chest Disease, NITRD, New Delhi. Dr. Vijay Hada, Additional Professor, Pulmonary Critical Care, Sleep Medicine, AIMS, New Delhi. The moderator for the session would be Dr. Sutaba Nyogi ma'am, Director IIHMR, Delhi. Ma'am, please, if you can join us on the stage. Before we formally initiate this session, I would also like to tell you that, as a HEAL Foundation, we also run a India Fights TB initiative that has been, running for past 1 year, in which we are trying to connect the key opinion leaders, doctors like Dr. Singla, Dr. Mattu, Dr. Hada, to the layman, so that, the layman can get the right information from the right people. And we are also trying to create patient support groups so that, the patients who are in need can be connected to the people who have already won the war against tuberculosis. So if any one of you would like to know more about the India Fights TB, you can get in touch with me, during the networking sessions. And before we formally start, can I have that video, please? India Fights TB.
A very good afternoon to all of you. Thank you organizers for putting up this very interesting and exciting panel. We have got eminent speakers in our panel today, which is on tuberculosis. So, in the benefit of those who are hearing about tuberculosis, I'm sure it's not for the first time that you are hearing what tuberculosis is, but tuberculosis is a very important problem that India is grappling with. And as India is committed to the UN SDG target to reduce TB deaths by 90% by 2030, there is a long way to go. So the findings of the latest survey indicates that the prevalence of tuberculosis in fact has gone up. It's primarily because of the fact that the diagnosis is nowadays becoming a problem. Firstly, because there was a break because of COVID, and because of many other factors which we will hear from our panel members, why it is now becoming difficult to see how, the access to tuberculosis diagnosis and treatment continues to remain a threat in many parts of India today. It's worth mentioning that India has done quite a bit in the last few decades in terms of strengthening the support structures, the program architecture, the implementation environment for tuberculosis control, and this includes mandatory notification of TB cases, integration of the program with the general health services, expansion of diagnostic services, programmatic management of drug-resistant tuberculosis. Nevertheless, there are certain challenges like delayed diagnosis, inadequate treatment, primarily for the patients who are seeking care from the private sector, and also MDR tuberculosis is a problem today. So, I would be asking specific question to our esteemed panelists. If you have any question in mind, please make a note of it, and then maybe we'll take up those questions after the session is over, after all the panel members have spoken their bit. So first question is to you, Dr. Rupak Singla, who is the HOD of Chest Diseases, National Institute of Tuberculosis and Respiratory Disease. As a doctor from such a reputed institute, I would want to know from you what have been the path-breaking innovations in the field of tuberculosis with particular reference to diagnosis.
Yes, I think very important aspect you have raised. You see, there was a time you think of tuberculosis clinically and you do a test, only 50% will be caught by this test, 50% will be missed by test. Secondly, when you are looking for drug resistance in the TB patients, and today you feel patient is failing to treatment, could be drug resistance. It used to take 3 months, 4 months, 5 months, up to 11 months. We published a study also on this, that the time lag between diagnosing drug resistance and suspecting drug resistance used to be in months, not in days or weeks. Today we have tests. In 2 hours, it can tell you whether TB is there or not, with quite a high sensitivity and specificity, and whether if TB is there drug resistance or not. So in case you know it within 1 or 2 days, you can imagine, you can start the treatment early, you can prevent the mortality, you can cut the chain of transmission. So all the things can be done, because diagnosis is the step 1 for tuberculosis.
So thank you, Dr. Rupak. And any information on the newer aspects of management part?
Yeah, again, you see there have been path-breaking research is done. Now we have newer drugs like bedaquiline, delamanid, predominant. We have newer new treatment regimens. They are a combination of 3 drugs or 4 drugs. And if you see earlier, we were forced to use injections, especially when we were giving drug-resistant tuberculosis treatment. And today we have the drugs of the regimen which are free of injections. An injection means pain to the patient, challenge to the program to arrange injections. It used to cause hearing loss, it used to cause kidney issues, but now it is totally oral medication. And if you see the efficacy, earlier using this injection-containing regimen, out of 100, only 50% will have treatment success. Not only in India, globally. There were 50% or less for MDR-TB patients, and something called XDR means person is resistant to more than 2 drugs. MDR is than 2 drugs. So there it used to be just 30%. Out of 100, only 30% are getting cured. Today with these new drugs, our program is giving this, and if you see the data, more than 1.3 lakh patients have been put on this under our national program, free of cost. In the field conditions, we have achieved a treatment success of more than 70%, which means a lot. You are preventing deaths, you are curing more people, morbidity is reduced, the cost to the patient and the families is reduced, the transmission is reduced. So these are very important things which are taking place now.
So thank you so much, Dr. Singla. So the takeaways from this question is that we have been able to reduce the time gap from detection or diagnosis to 2 hours, which was not the case 2 hours, which was not the case earlier. And also the treatment of MDR-TB, we have switched over from the injectables to oral medications, which would obviously enhance the adherence and the compliance also. So my question to Dr. Sanjay is that although we are developing on all fronts, what do you have to say about the access to quality TB care and services in India?
Thank you for this question. So, before coming to the question, I would like to give some information. When we say that India is having the largest burden of the tuberculosis in world, so we need to understand that it is, if we are seeing the per 100,000 population rate, there are the 35 countries still who are having more rate. So because of the population, these numbers comes. Now coming to the progress we have made, already the program has done very well. Like before this, we had the Millennium Development Goal of the United Nations. Program achieved them successfully for the TB program. Currently we are having the SDG targets also. This is also of the Sustainable Development Goal, again of the United Nations. And when we are comparing with the other countries in the world, so you can understand we are having two very important parameters, reduction in incidence and reduction in the mortality. And India is doing almost a double of the rate in both the parameters. Reduction rate is a double of the other countries if we are comparing. So this is as far as we are having the progress. Now coming to the quality services, we are providing best of the quality services in the program. As Dr. Singla mentioned, like earlier we were using the microscoping where we were looking for the whole bacteria. Now for the diagnostics, we are having the molecular diagnostics. And if you would like to know the number of the molecular diagnostic, not only district, we have reached up to the block level. These molecular diagnostics are available. These are more sensitive. So the number of the TB detection has been decreased. Now coming to the delay part, so we are having different mechanisms are there. We are having community involvement also. We are having this sample transportation from the rural centers to the this. We are having human carriers from the postal departments has been involved. And when we are consider the medicine also, we are having the quality medicines of the international standard. They are being provided. And even you can think of any most advanced medicine which is available for the tuberculosis is available under the program. We are having all the digital technologies also which are available under the program. You can understand world over, if you want to see over management system for the TB program, which is the web-based portal, Niksha portal. It is one of the biggest health program portal, and world over we will see that even the most of the developed countries, they are using the Excel-based system. And here we are having the live reporting of the TB case, where the web-based, case-based information is there, and from diagnosis up to the treatment and up to the follow-up of the TB patient, all the information can be obtained on the online portal. So that is how we are providing these services under the programmatic conditions. Yeah.
So thank you, Dr. Sanjay, for very beautifully specifying how we are going ahead with the diagnosis and treatment. Now, because we are talking about the access, although the services may be available across the entire spectrum of the health services, we all understand that there are certain impediments which actually act as hurdles when it comes to seeking care. Some of the well-known determinants are like poverty or malnutrition or overcrowding, and most important of all is the stigma and the discrimination. So my question to you, Dr. Vijay, is that given this kind of a complicated scenario, I would say, how do you think we can address these important determinants which are, I won't say these are modifiable, but these can certainly be overcome with our efforts?
So, good afternoon everyone, and thank you for this nice question and pertinent also. So if we talk about tuberculosis, when I was student, most of the teachers were teaching us like TB is a disease of poor. So if we say that poverty is the center of this tuberculosis, so this statement is not wrong. Rather, anyone who is poor and coming with any respiratory symptom, first diagnosis we keep is tuberculosis. So you can imagine that how much risk factor for tuberculosis. The poverty itself is linked with TB by multiple factors. For example, the living condition of poor is so bad that they will be living in crowded area. Their houses are not well ventilated. There is no good light there. Also their nutrition is so poor, so they will be mostly undernourished. Then poverty is also associated with illiteracy. They will not be literate. So their knowledge regarding health-seeking behavior will be very, very less. So again, even if they are having symptoms, either they will not seek any health advice. If by chance they were brought to health services and they were told that they are suffering from tuberculosis, there are high chances that they will not take treatment. And by chance, if somebody has started, there are high chances they will not complete. So if you say that everything is so complicated, so these factors need to be addressed. Unless we address these factors, the eradication of tuberculosis will always remain a distant kind of a dream. What we can do, I think the most important thing is, whatever policy is government making, we should keep that health should be in all policies. So any policy they are designing, health should be kept into that. Then we should think that poor patients should get a priority, maybe regarding education, making them more aware, making some arrangements so that their poverty status can be improved, providing good houses with well ventilation. So I think these are few steps which are required to at least to curtail these factors to some extent.
So thank you, Dr. Vijay, for very pertinently highlighting the fact that health should be mandatorily made a kind of a component of all policies. Now, taking forward the discussion from here, since we are talking about different departments incorporating health as a factor, Dr. Sanjay, how can we foster collaboration between different departments?
Actually, this is very important questions when we are considering management of tuberculosis. And as the other panelists mentioned, when we are considering the tuberculosis problem, it is not only a communicable disease and the bacterial disease. It has the many societal factors also. As Dr. Hada was mentioning, we are having different conditions which make it more vulnerable, like undernutrition, poverty, overcrowding, hunger, and then some habit-forming substances are there, tobacco consumptions, alcoholism, drug abuse. So these are the certain conditions. Immunodepressants, HIV infections, diabetes mellitus. So these are many factors which makes basically this TB more common in these population who are affected by these factors. So it is more of societal disease than being a communicable disease. As far as the program is concerned, as a public health program, we are providing best of the diagnostic services and best of the quality medicines. But still, to manage these societal factors, we need the support from all other sectors. So when we are having sectors, among the health sector also we are having public and private. So we need the support from the private sector also. We have identified that the 23 line ministries are there, which are directly or indirectly associated with the health related issues of the TB disease. And we are having collaboration with them, like Ministry of Labor is there, Ministry of Railways, Defense, and Ministry of HRD are there. So it is a 23 line ministries are there which are associated with that. Among them, one is the Ministry of Rural Development and Panchayati Raj institutions, where we are having this concept of the TB-free panchayats. And we want to engage these Panchayati Raj institutions that we are having a number of the parameters are there where they need to fulfill in their Panchayati constituencies, and after that they can claim on annual basis that they have complied with all the parameters, and that territory may be declared as a TB free for that particular year, and claims and awards schemes are there. So we need the support from all the sectors. Another scheme which program is engaging with through the partners are like we are having corporate sector engagement. We are having a corporate TB program is there where under the CSR responsibility we are engaging with many corporates, and when we are having this sectoral approach, intersectoral coordinations, we are having certain parameters how they can contribute, like it starts, they can have the TB free workplace policy. There are the certain parameters, awareness, how the this airborne infection control practices and screening of the employee may be done in their health settings, and then Other than this, they can come forward to support, to go into the community level where this screening activity may be done, and then other than this, they may come up with the support with some diagnostics, and they can supervise the treatment also. Other than this, we are having, there is one more program has been launched. It is Pradhan Mantri TB Mukt Bharat Abhiyan, where we are reaching to the community, and from individual level to NGOs and industrialists, even the elected representatives, anyone can come forward and adopt the TB patients. For the nutrition supplement is one scheme. Other than this, they can be supported by vocational services for at least 6 months, and then nutrition supplements. So that is why this support from the sector other than the health sector is very important, critical when we are looking towards our ambitious target of achieving this NTB targets in India. Thank you.
Thank you, Dr. Sanjay. Very beautifully you have pointed out that tuberculosis is more of a societal disease than anything else. And so we do need the collaboration of different sectors, which includes the private sector and different departments like labor, railways, defense, HRD, whatever you mentioned. Now, is there any model or best practice you think we can learn from this type of a collaboration which will provide an impetus to our implementation of successful TB programs? And this question is for Dr. Vijay.
Thank you. I think in continuation with Dr. Sanjay, so although we know that Government of India is running a very robust kind of a system under NTEP, and most of the patients are getting free of cost diagnostics, free of cost drugs, but still there are peculiar problems with the patient. I will give you an example. For example, a truck driver is there who is diagnosed with tuberculosis, but he is continuously driving. Today he is in Delhi, next day he will in Ahmedabad, maybe 2 days later he will be somewhere else. So how we will assure that that patient continues his treatment, or let us say he develops some kind of problem. So how to tackle that? So there are few public-private collaboration which have projected like a model, and they have shown that if done in a proper way, we can achieve a better result as compared to today's. So one program is run by Apollo Tyres. So what they have done is they have taken responsibility of all the truck drivers. So all the truck drivers, they cater, and whosoever is having symptoms suggestive of any respiratory symptom, they will screen them for tuberculosis. If they are diagnosed, they will get treatment. So they need not to worry that today I am on duty, I have to take leave and then go back home and then go to clinic to make diagnosis and then start treatment. Similarly, if somebody is living in Mumbai, they may be knowing BEST. So BEST is probably taking care of electricity and transport in Mumbai. So they are also taking such kind of models, and what they have done is at each bus terminal, they have started these kind of services. They have started diagnostic models there, they have put molecular testing machine there, they have started drugs there, so that there is little gap and they can outreach their patients or those who are needy. Similarly, there are other private organizations also, for example, Goodrick Tea. So there are so many. So it will be very difficult to see that which model is best, but we need to see that which model is fitting in what context. But these are few examples where we need to think out of blue, and we need to support, or we need to think that how we can support the existing system. Another example is Medanta Hospital. What they have done is they have arranged 2 or 3 ambulances. In the ambulance, they have kept an X-ray machine. So currently, national program do not support X-ray. So if we do X-ray also in symptomatic patient, then chances of diagnosing tuberculosis goes a little higher. So you can think that how they have enriched the already existing system. So they will carry that ambulance with X-ray, and maybe once in 6 weeks, and simultaneously they have, I think, screened almost whole of the Haryana. Their target is whole Haryana, and they are contributing in loads of ways. So these are the few examples that what can be other models which can be applied to other part of the country.
So thank you, Dr. Vijay, for highlighting some of the examples which includes public-private collaboration and partnership, and with specific reference to the one which you talked about, the truck drivers. I think that for the media partners, I mean, you should all take a note of it and try to make these stories as success stories and publish them as success stories so that others also get to know from us. Taking the discussion forward, Dr. Rupa, I think you are the founder of Difficult to Treat TB clinics. So can you please tell us something about this whole concept and how you think it can have a positive impact on the implementation of TB programs?
Thank you. You see, today the treatment of TB is very, very complex, as we have already seen. So many factors influence the treatment. Plus in the field we have seen that there are cases who are difficult to treat. And every doctor in the periphery, whether medical officer, district TB officer, they do not have access to the best brains of the country, that is the national level consultants. So we sat down, we found, it's called NITRD, that is the name of my institute, National Institute of TB and Respiratory Diseases, CTD, NTF, Difficult to Treat TB Clinic. So if you see in these three organizations, our institute, the apex institute of the country, the Central TB Division, which is the apex technical and managerial component of the Ministry of Health, and the National Task Force, which comprises of all the medical colleges of the country. So together we formed this clinic so that the modus operandi is that there is a difficult case, the doctor in the periphery, whether medical officer or district TB officer, they present this case online, and we have the hubs all over the country. Today each district has got a computer and the facility for online learning and sharing the information. So through this, they present a case, and then the case is discussed in the meeting. There's an interactive discussion, and also through this clinic, we talk about the national guidelines, how a case should be managed. So we are updating their information about the national guidelines, that in this scenario you do this, in this scenario you should be doing this diagnostics test you can use, these drugs you can use, these drugs should not be used. So indirectly through the case discussion, not only we are providing the solution to that particular case, we are doing the capacity building of the most peripheral doctors of the country. And we also had the vision that such a model should be existing in each and every state. And today you'll be glad to know all the states of the country, all the union territories of the country, they have state level difficult to treat TB clinic. They have identified the state level experts who moderate this kind of clinic. The cases are presented within the state from the peripheral doctors, they are discussed, and we get the solution from these clinics. So this is a revolution in the country. Now each peripheral doctor has an access to a consultant who is expert in the field of TB. And also there is a capacity building. So that way I feel this kind of clinic is unique to our country. Other countries like Afghanistan, the Middle East countries, Bangladesh, they are trying to follow us to create a similar model in their country. So I'm very happy about this, that this concept has worked, and we have full support of the Central TB Division in taking it forward.
So sir, how does it work? Like, is it a weekly thing or a monthly thing, the clinic, or it's a physical clinic?
So this is an online clinic. It works on a hub and spoke model. Like for the national level clinic, we are the hub. We conduct it once or twice a month. And the spokes are the various districts where these doctors are sitting there. And each state, some of the states are also conducting it twice a month. Some are conducting it once a month. So it is conducted like this, and then it's an interactive case discussion when the cases are presented.
Something like
Thank
a
you.
telemedicine that we are having. It's something like a telemedicine.
Yes, like a telemedicine. Actually, it is much more than telemedicine. It is not that lecture is being taken like that. It's an interactive discussion. Difficult case presented, and then we also discuss that as per our national guidelines, WHO guidelines, how best the patient should have been treated.
Yeah, of course. So in this era of digital health, one cannot ignore the power of technology. And so I think digital health has revolutionized the whole process of diagnosis and treatment, including in India. So Dr. Sanjay, in your opinion, what are the different ways by which we can harness this power of digital health or digital technologies for TB surveillance, monitoring and evaluation?
Thank you. So I will take from Dr. Singla sir. Already one example has been shown by the institute how we are using the this technology when we are treating most difficult type of the tuberculosis, the DRTB. And in DRTB, basically the variation is so large, patients has to be monitored regularly, and at any stage we need to change the treatment also. There are some complications also, adverse drug reactions monitoring is needed. So for this is one of the best example we are having through the NIRTD, where we are in the Eco Hub system is there, and on those platforms we are having the live sessions, and we are demonstrating. Sometimes surgery has been also demonstrated how the surgery are done in the TB patients. So
during COVID time, we used this platform to educate the people about COVID and TB, and also in the scale-up of the newer drugs. When the newer drugs came to India, like bedaquiline, people had a lot of concerns that whether this is effective or not, it can cause cardiotoxicity, should I use it or not? So then we shared our own experience in our institute with the rest of the country, that no, we have used it, they are good, and they are comparatively quite safe. So that helped in scaling up of the newer drugs very fast. In 2018-19, there was 70-80% increase in the uptake of the newer drugs. So this role can also be played by this clinic.
So now coming to the digital technologies, like if any program really want to be a successful program, we need to utilize all the modern technologies, and these need to be implemented in the programmatic conditions. Already the TB program is utilizing many of the these modern technologies in our program. Like as I mentioned, we are having this web-based system is there, which is unique in world over, and it has been presented in world conferences also, in Geneva meeting. Our management system and reporting and recording system of the TB cases is such a robust, and it is a unique example in world over. Even most of the world country, they are not doing it. Another aspect of the digital technology under the programmatic condition we are using is that we need to ensure that patient takes medicine completely. They are compliant or they adhere to the treatment, because TB treatment usually in simpler TB it is of 6-month duration, and when it is DRTB cases, it may vary from 9 months to the 18 month of the duration is there, and we need to ensure that patient complete the treatment. So for this, we are using the advanced technologies are there. One is the 99 dot technology, where we are having one envelope cassette is there, and when this envelope is open and the pills are taken, so a patient need to make a mock call on these numbers, and these are registered in our Nexus system that patient has taken medicine. Other type of the technology for the adherence is we are having the MARM boxes. It is the medical event and reminder monitoring. So the medicines are kept in the box, and whenever the patients open the box of the medicines, and usually like even the children may open the box, but it may be for some second. So we also monitor the times. After that, it get recorded that patient, as a proxy, that patient has taken the medicine. Other than this, we are having Nikshay Arogya Sathi app. It is the citizen and patient faced application is there, where we are providing all the important critical information to the citizens and the patients, like who persons may be having tuberculosis, they may ask any questions, so that is supported. Other than this, if somebody is having or thinks that he or she might be suffering from the tuberculosis, where they need to seek the help. So through that app, they can identify the nearby the location of the health facility nearest to their residence, and they can go there. Other than this, we are having the some incentive schemes are there under the TB program, like we are giving 500 rupees for the TB patients every month as a nutrition supplement. We are giving some transportation support to the tribal patients also one time. Then we are having another incentive schemes for the private providers also for this. and these are basically given through the technology. We are having the direct benefit transfer so that money directly goes to the account of the TB patients. Then we are having other applications are there, like one app is the TB Manage app, where again the NITD and HEAL Foundation and CTD were the partners, where we are having this, how the DRTB may be managed, and this is being supporting management of TB through the support to the TB service providers. And other than this, we are having AI-based technology are also being utilized in our program. Like we are having this for X-ray reading, AI-based tool is being utilized. We are also exploring, like we are having the line probe assay, basically which is utilized a test for knowing that which of the second-line drugs may be resistant or susceptible. So that is basically done manually, and we are having this AI reading. It will save the time also, and the quality and accuracy of the test will be increased. And we are having, like, we can predict through the AI also lost to follow-up cases. How the lost to follow-up cases may be predicted, like this particular TB patient is more likely to be lost to follow-up and more likely to incomplete the treatment. So our staff goes there and visit the patient's house and the families, so that they may be again brought back to the this TB completion treatment may be done among such persons. So these are some of the examples we are already utilizing under the TB program, how the technology is supporting this our program.
Yeah, thank you, Dr. Sanjay. It's very heartening to see how India is contributing in many different ways through its innovations. So one of the innovations is again Manage TB app, Manage TB India app, which was recently developed by the National Institute of Tuberculosis and Respiratory Diseases. So Dr. Rupak, can you please elaborate on this for the benefit of our audience?
Thank you. You see, again, this app is very close to my heart. When we saw, you see, the treatment of TB today is very, very complex. Newer drugs, new regimen, newer diagnostics. Not only that, the guidelines for WHO are changing every 6 months. New evidence is coming. Accordingly, the Indian guidelines for managing TB, drug-resistant TB, they are also changing. Then you see, can you imagine there are 20 weight bands for TB today? If you see, depending on the age of the patient and depending on the what type of resistance you have, there are 20 weight bands. Can anybody remember this? If there are comorbidities, like the treatment will be different if somebody has liver disease, somebody has kidney disease, somebody had the heart disease with prolonged QT interval, somebody had hearing problem, treatment will be different, somebody has any eye problem, the treatment will be different. Similarly, you see, if the laboratory tests are done and you find your function tests are deranged, treatment is different. Kidney functions are deranged, treatment is different. ECG has abnormality, treatment is different. Hemoglobin is low, treatment is different. So you see, what I want to say is, to take into account all of these factors to make a regimen is practically impossible, especially for private practitioners. You see, TB is just one part of their life. They have to see diabetes, blood pressure, so many other things they have to see. So we thought that to help these colleagues, especially the private sector people, and not only that, we found ultimately even medical college professors, the corporate hospitals, everybody is trying to use this app. It's a very simple app. You feed the patient information, clinical data, you feed the laboratory test, you feed the X-ray data, you feed the comorbidities which are present. It takes 10 to 11 minutes only, available on the iOS and the Android, free of cost. Anybody can download this, and it gives you that for this particular patient, tailor-made for that patient, having this age, this gender, pregnancy, no pregnancy, drug-sensitive, drug-resistance, any comorbidity present or not present. It takes into account all of these factors, A plus B plus C minus D plus E plus F and all that. It gives you a final regimen, that this is the drugs which should be used, these are the dosages which should be used. And not only that, you see, once we made this app, we approached the Central TB Division for approval. They said, no, you do the validation in different states, whether how this app is working compared to the human, the doctors who are taking this. And we found there was more than 99% concordance. What regimen the app was making and what were the doctors who were, based on this information, what they could have given. So subsequently, the Central TB Division, the apex body in the country, they approved that this app can be used across the country for treating the patient as a guidance. Of course, all the apps in medical practice are guidance tools. So accordingly, once we feed this data, the correct regimen comes, and our colleagues, they can use this in the interest of the patient. Also, it tells to the practitioner how he or she can link up with the national program. Like some of the new drugs are not available to the private practitioners. So it guides them that by using this, you can connect to the nearest district TB officer who can arrange these medicines to you. It also tells your patient is serious, needs hospitalization. It also tells them that no, this drug should not be used, this drug will be better for him due to this reason. So it gives entire gamut of the information to the physician how to best manage my patient, tailored to that patient. Thank you.
I will just update one thing on Dr. Singla sir's last statement. Like there are the certain DRTB medicines, Secules, which are accessible through the programmatic conditions only. So it is not like that they are not available with the private practitioners. They are not openly available in the market. And for these drugs are available under the program for the private patients also and private provider also. The medicine may be kept in their clinic. There is certain conditions like because these medicines are to be given as a part of regimen to the patient. So it is not like that private practitioners can make their own regimen and can give these very important medicines, because these are the reserve medicines and given to the TB patients who are not being treated with the normal medicines. And if they can be utilized in any way, then their importance will be lost and the resistance will be also developed against this medicine. That is why this accessibility is restricted through the programmatic conditions, and medicines are available to the private practitioners also. So this I just wanted to update. Yeah.
So through this app, they will display the phone number, mobile number of all the districts of the country, so that private practitioners in Gujarat knows I have to contact so and so. They can link up with them, and then they can get the medicines, as Dr. Mattu has informed us. So it is available to all the practitioners, but through a mechanism. You see, we don't want to lose these important medicines in case they are used inappropriately, injudiciously. It can cause resistance against these very good medicines, which nobody wants in the country.
Yeah, indeed a very interesting application to provide customized services to the patients. So my last question to you, Dr. Vijay, that we know AIIMS as an apex and the apex institution in the country has all facilities, the best of the treatment avenues are available here. Despite everything, what challenges do you see when you treat patients at AIIMS?
Thank you. I think half of the question you have already answered. There are certain advantages of working at AIIMS. So we don't face many challenges as far as diagnostic is concerned. Even availability of drugs, these are not a challenge. Most of the time, what challenge I face is my patient usually refuse to accept that they are having tuberculosis. So if I make any diagnosis, they will first ask, क्या मेरे को TB तो नहीं है ना? So you can imagine that still they are having so much of high level of stigma associated with tuberculosis. So I think biggest challenge still remains, and I think will remain for some more time unless there is a proper education awareness among patients. So I think that is the biggest challenge which I am facing day in and out.
Thank you. Leading to this question, that we have taken long strides in diagnosis and management, but stigma still remains a challenge when it comes to the tuberculosis. So I would like from you and Dr. Singla also that, through media, we would like to take this message, that when a patient is started on a regime, be it, the DSTB or the drug resistance TB, when they stop spreading the disease, so that it is not taken as a stigma, in the family, in the relatives. So if you can guide us on our media friends on that.
Yeah, very relevant question. So most of the time, we explain this to the patient, that especially those patients who are having sputum positive tuberculosis. So they are highly infectious. So we always tell them that please start treatment, and within few weeks, your bacillary load, means the number of bacilli or number of pathogen in your sputum will go down. Especially after intensive phase, they are almost non-infectious to others. But as soon as they start taking, maybe 2-3 weeks down the line, their infectivity goes very much down. So this we always tell, but still probably is long-standing and lots of contribution from the TV serials and movies where they will show TB, blood and die. So that everybody has that kind of image. So that will be one reason.
Sir, you would like to add?
You see, counseling is very, very important for a patient of TB. He or she doesn't know what I am suffering, why I am suffering, what should I eat, what I should not eat, how long the medicine is to be given, do they have any side effects. So unless at the beginning itself, you tell to the patient and to the family, equally important. So this counseling has to be done in our hospital. What we have done is, patient is diagnosed as TB in the OPD. There is a room number 107. They go there, either individually or in groups. There are posters are also displayed about the food, about the medicine, the duration, side effects, and they are told about this. It takes around 10 to 50 minutes per patient. So that at the beginning of this treatment, he or she is aware about the various aspects of TB, and they are told that it is curable, provided you take it regularly, proper dosages, and for full duration. So it plays a very, very important role for the compliance of the patient. Thank you.
Yeah, thank you everyone.
I would like to also add on this, like when we are saying the stigma, why the stigma usually comes. So we, mentioned to manage this particular aspect, we need to give this correct information through the counseling. We are counseling this over TB patients also, their family also, and for community awareness we have to have the different technologies like social media, newspapers are there, we are having the video, medias are there, and to cover up the fear, we need to see that if we are saying Indian scenario, we can understand up to 94% of the total TB cases are the DSTB. And in DSTB, the treatment success rate is very high. It is near about or above more than 90%. So we need not to fear now that the patient is going to die because of tuberculosis. In DRTB cases also, earlier, like as Dr. Singla mentioned during his earlier comments, that even 50% of mortality was there. Even in DRTB nowadays, the success rate is varying somewhere between the 70 to the 85%. So newer medicines are there where this success rate has increased in the DRTB cases also. And DRTB cases percentage is very low if you want to see the proportion of the total TB cases. So we need to give the right kind of information to the community and give the message that this disease not is such a dreadful disease if we are diagnosing it early and we are treating with the right kind of medicines. And another message we need to give, that in initial phase of the treatment, both the patients, family members and contact has to take the this airborne infection control practices at least for 2 to 3 weeks. So these messages should go clearly so that this stigma will be reduced. So these are some messages I would like to highlight.
I would also like to add, you see, the most popular person in the Indian cinema, Amitabh Bachchan ji, even he had the guts to say, I had TB, I took the medicines and I was cured. And he's spreading this message to the others in the society that you should also get your testing done in case you have TB, and then you can be cured. And I think our media friends, they play a very, very important role in spreading this message that TB is curable, it can be diagnosed, free diagnosis, free treatment facilities are available through our national program across the country.
So there is one comment for the this media also, media audience is there. Yesterday only I would like to praise this Times of India. There was a news article that a pregnant lady was having the spinal tuberculosis. Not only she delivered the healthy baby, she was cured of the paralysis, everything. The surgery and TB medicines has cured her completely, and she has given very healthy baby. So these kind of message and articles usually create awareness in the community, like even the spinal tuberculosis, because of many times we were saying that we are having this permanent paralysis was there. So nowadays we are having the good medicines, and there are the examples which are there where they are like spinal tuberculosis there and the pregnancies are there, and both the outcome is very good and favorable.
Thank you, sir.
So Thank you everyone for your very important contribution. I think a lot of responsibility now our media partners have to shoulder. And primarily for three things that as has been echoed by all our panelists, that we need to create awareness in the community. So I think this can be best done by the media partners. Next month is the TB awareness month, the month of March. So I think we should all pull up our socks and try to do the best that we can to create awareness. First of all. Second, to promote health-seeking behavior and to garner the support of the communities and stakeholders behind these TB prevention programs. I'm sorry we are running out of time, so I don't think we will be able to take questions from the audience.
Yes, so we are already running late, but if you have any questions, so we can get you in touch with our speakers later. And with this, we'll conclude today's session. I would request Mr. R. Shankar to please come on stage and present token of appreciation to our speakers and moderator. Thank you so much, dear panelists and our moderator, Dr. Sutapa. It has been a wonderful and insightful session, and I hope our media friends would have gathered some really important information about tuberculosis from this session. So moving forward, now we are also delving into one of, important sessions when it comes to the health, navigating medical ethics. So ethics has always been, a very thin line between what you practice and what you preach. So for that session, I would like to request the speakers from the next session to please come on the dais. I'll start with Dr. Rajiv Gautam, Corporate Officer, Horiba Limited, Japan, President, Horiba, India. So please, if you can join us on the dais. Dr. Girish Tyagi, Registrar, Delhi Medical Council, President-elect, Delhi Medical Association. Sir, if you can please join us on dais. Ms. Manisha Singh, Partner, Corporate Law Group. Dr. Sunil Khetrapal, Director, Association of Healthcare Providers, APHI. Mr. Atul Sharma, Founder and Managing Director, Healthscape Business Solution Private Limited. This session would be moderated by Ms. Krishna Sarma, Founder and Managing Partner, Corporate Law Group. Ma'am, if you can please join us on the stage. पैनल ये चेंज तो करो, सेकंड उसका लगाओ ना सेशन का. हाँ, पीपीटी नहीं है सेकंड सेशन. अरे सर, सेकंड सेशन का बैकग्राउंड.
The same thing. You already have it?
It's already there.
Okay, you can give it to me.
Just a minute. क्या कर रहे हो यार? टीम का पाना यार. नहीं, पुराना चल रहा है. So if I can also request everyone to, please sit in front of the pictures, so that would be good for the video. One chair for you. For your hand.
No, it's okay. It came later on on the screen. Another one?
Good afternoon. I have the privilege, my name is Krishna Sharma. I'm the managing partner of Corporate Law Group. And it is a law firm that specializes in the healthcare sector. So today's topic is navigating medical ethics. It's a very topical subject currently because of a lot of developments, legal and regulatory. So what we are going to do in the next 45 minutes is we'll start with a small presentation by Manisha to set the stage as to what the regulatory environment is. And then we will get into discussion. I'll ask some questions, but also I want it to be free-flowing. And I also want it to be interactive, okay? So I'm going to cut short what I was supposed to say and depend on Manisha to say that. But prior to getting into that, let me just quickly introduce the very stellar stakeholders that we have in the dais here. I start with Dr. Girish Tyagi. He's a prominent figure in Delhi's medical community with over 40 years of experience as a general physician and diabetologist. Dr. Tyagi runs a successful clinic in Shalimar Bagh. No? Okay. He is a registrar of the Delhi Medical Council, which is a statutory body constituted in 1998 under the Delhi Medical Council Act 1997, and which is vested with the powers of regulating the practice of modern scientific system of medicine. Dr. Tyagi is also the president-elect of the Delhi Medical Association. Dr. Sunil Khetrapal is Director, Association of Healthcare Providers, India, a leading not-for-profit organization representing the majority of healthcare providers nationwide. APHI's mission focuses on enhancing the quality, accessibility, and affordability of healthcare services while advocating for rights and interests of healthcare providers. With over 40 years of extensive experience, Dr. Khetrapal is esteemed as a general physician and diabetologist. I next come to Dr. Rajiv Gautam, President of Horiba India and Corporate Officer of Horiba Limited, Japan. Horiba has a vast spectrum of technologies catering to industries spanning automotive, medical, semiconductor, environmental, and scientific sectors. Dr. Gautam is a BTech in Chemical Engineering from IIT Kanpur, a master's degree from Drexel University, a doctorate from University of Pennsylvania, and an MBA from the University of Chicago. Prior to Horiba, he was with Union Carbide, EOP, and a president and CEO at Honeywell Performance Materials and Technologies. Then I come to Mr. Atul Sharma. He's the founder and managing director of Healthscape Business Solutions Private Limited, which offers strategic consulting and business advisory services to the entire healthcare segment. He was the commercial head of MSD Pharma, where we actually worked with you. Then last, my colleague, Manisha Singh. She's partner Corporate Law Group. She leads CLG's ethics, compliance, IP, and regulatory practice. Manisha has about 25 years of practice and has domain expertise in these areas. Prior to joining CLG in 2007, Manisha was a litigating lawyer for 6 years before the High Court of Delhi and the Supreme Court of India. So to set the stage, I request Manisha to make a very short presentation. Keep it short, 7 to 8 minutes, okay? And then we will start the questions. Thank you.
So thank you, Krishna, and good afternoon to the esteemed panelists and to all. So first of all, I wanted to thank you, thank Heal India, Heal Foundation for giving me this opportunity. So as a lawyer, I've been asked to, talk about what is there in the regulations so far as ethical promotion of pharmaceutical and medtech products are concerned, and the interaction between industry and the doctors. So to begin with, I just wanted to kind of set the context. So we all know that the direct to consumer promotion is not permitted in India under the law, and we have a particular specific act called Drugs and Magic Objectionable Advertisements Act, which actually prevents the companies to claim that a particular product can diagnose, cure, mitigate, treat any of those 59 health conditions which are listed out in the act. And these conditions are pretty much, they cover the entire universe. So therefore, what is left with the companies which come out with, the new therapies, and also the doctors to understand, what is there, what has been innovated, how does that happen? So the companies are permitted only to kind of reach out to the doctors, and therefore the engagement between industry and the doctors it becomes very important, and are regulated under different codes. One is the MCI code, which regulates the doctors, and the other is the UCPMP, which is the Uniform Code for Pharmaceutical Medical Practices, which kind of regulates the industry. Now, quickly, I would just like to go through, what is there in the MCI code, what is prohibited, what is permitted, and we all know that the gifts, travel facilities, and hospitality, the registered medical practitioners are not permitted to accept such things from the industry. As far as what is permitted, medical research, you can get into engagements with the companies for medical research purposes. You can accept funding through approved institutions from such, sectors like pharmaceuticals and medical devices. Going forward, even cash and monetary grants, RMPs, the registered medical practitioners, they are not permitted to accept such cash and monetary grants in their individual capacity. They cannot endorse any drug product of the industry publicly. In terms of what is permitted, affiliations are permitted, and we are going to talk about this because the new regulations which were kind of kept in abeyance, they did not permit certain things which are permissible under the MCI code at this point in time. So the RMPs can actually get into advisory capacities as consultants, researchers, as treating doctors, or in any other professional capacity. They can have that engagement with the industry, provided their professional integrity is kind of maintained and the patient's interest is not compromised, and such affiliations are within law. Now, I'm just touching upon the generic prescription bit because the new NMC guidelines also talked about that. As of now, the MCI code says that the doctors have to prescribe, when they are writing their prescription, it has to be done in generic names and in capital letters. It does not kind of preclude the doctors from writing, specifically it does not preclude the doctors from writing the brand names. So on UCPMP, so we've covered the, the code which is there for the doctors. Now I'll cover whatever is there for the industry. So now, in this particular code is voluntary as of now. However, there are, apart from the gifts, travel facilities, hospitality-related provisions, there are also provisions on claims and comparisons which the industry can make, the textual and audiovisual promotional materials, how the samples are to be given to the doctors. All that is kind of covered under the UCPMP. I will only touch upon the sample bit from this particular slide that I have put up. So the doctors, the industry can actually give to the doctors samples, free samples. Of course, it has to be labeled in a particular way, but there is a limit to that, it can be, it will be limited to prescribed dosages of 3 patients only. In terms of gifts, travel facilities, hospitalities, and the cash or monetary grants, it's pretty much the same as whatever is there in the MCI code. That is applicable for doctors. This is applicable for the industry. However, what it says is that, in terms of the funding for medical research, UCPMP actually goes a step further, and it says that such study can only be, funding can only be extended through approved institutions by modalities laid down by laws, rules, guidelines adopted by such approved associations and institutions. We must also, there is a particular clause in the UCPMP which says that wherever any item is missing, it is the MCI code that would prevail. So much for the UCPMP and the MCI code. But we know that we have a new act in place since 2019, which is called the National Medical Commission Act. And the rules are yet to be framed. There was one rule that came out last year, which was National Medical Commission Registered Medical Practitioner Professional Conduct Regulations 2023. It introduced several new concepts, but it was also very prohibitory. And because of the concerns being raised, it was kept in abeyance. I will cover only 3 points. One is because we are talking about the RMP industry engagement, I will talk about that. It actually had provisions on gift, travel facilities, hospitalities, cash or monetary grants. They were similar to the UCPMP and MCI code, but it went beyond that, whatever is permissible, and it said that the RMPs cannot accept consultancy fee, which is permissible under the MCI code at this point in time, from pharmaceutical companies or their representatives or commercial healthcare establishments, medical devices companies, corporate hospitals under any pretext, which means that whatever the consultancy arrangements that the doctors could have earlier, if this were to make, if this particular regulation was to be made final, then, that would not happen. Then the second thing was that the RMPs were precluded from getting involved in any third-party educational activities like this continuous professional development. I'll talk about that. This was a new concept that was introduced under these regulations, now in abeyance. They could not participate in seminars, workshops, symposia, conferences, etc., which involved direct or indirect sponsorship from pharmaceutical companies or the allied healthcare sector. We talked about so much in the previous, session that there has to be collaboration, there has to be, we have to attain the larger objectives. But from the way these regulations were, the private sector could not be, involved in providing sponsorships indirectly or directly. Now, the only thing that was permitted was that the RMPs could receive salaries from these companies as employees. And of course, certain things like clinical trials, which was not in contravention of law, was permitted, but it had to be clear, transparent, and open to scrutiny, which was absolutely fine. I go to the second point from the 3 that I want to cover. It is the Continuous Professional Development Program, a new concept that was introduced. It went beyond these, clinical updates or research scientific writings, and it was like, it covered everything as to what meant a CPD. And what the regulations stated was that, the RMPs will have to attend every year, totaling to at least 30 credit points every 5 years. And these, who will be doing this CPD? Only the recognized medical colleges, health institutions, and medical societies, and some of the other institutes which were authorized by the Ethics and Medical Registration Board, who could offer such trainings. Now, going forward, I just wanted to also talk about the fact that these CPDs, who could deliver, I've already covered. Who will decide on the content and implementation of these CPDs? These institutes. And with regards to the approval of the content and delivery and review of these programs, it had to be done by the Ethics Medical Registration Board. Now, I think this is my last point, where prescription of generic medicines, much talked about thing in the media. So these regulations read, there's one clause read with its guidelines, which meant that The doctors could prescribe only by generic names, when they are writing their prescription. And the last one, that, the state medical councils and the EMRBs were given the power of the civil court to decide on any violation. So I will, put a stop
Thank
here
you.
and hear the rest of the speakers as to what they have to say about the medical ethics.
Thank you. Thank you, Manisha. Actually, Dr. Tyagi just told me that he has to leave for Jaipur. And I don't want to kind of, forego the hearing from him. And I actually give you the floor, Dr. Tyagi, to speak a little bit in the context of, what Manisha presented, all that you envisage in this area for medical ethics. Thank you.
Yeah, thank you. First of all, Manisha, you told about that NMC regulation. Of course, they are kept in abeyance at the moment, but in a few days or months, they will come into force. What is the we should know what is the difference between the IMC regulation 2002 and NMC regulation 2023. Major difference is that with every professional misconduct or unethical behavior, which is described in the NMC regulation 2023, which was also described in IMC regulation 2002, now there is a level of punishment attached with these NMC regulations. That means with every professional misconduct or unethical behavior, there is a level of punishment attached. There are 5 levels of punishments, like level 1, 2, 3, 4 and 5. Level 1 is advisory. That means the State Medical Council or Ethics and Medical Registration Board can advise you or give you warning. Level 2 punishment is your name can be removed for 30 days. Level 3 punishment is your name can be removed for 3 months. Level 4 punishment is your name can be removed for 3 years. And level 5 punishment is your permanent removal. So, Manisha ji told about that, about gifts, travel facilities, etc. They come under the level 3 punishment. That means if a doctor receives a gift, travel facility, honorarium or any kind of facility to him or to his family member, his name can be permanently removed for 3 months. That is the level 3 punishment is there. So, previously the IMC regulation, there was no level of punishment attached. Either it is the discretion of the State Medical Council whether they are giving a warning or a 1-day punishment or 2-day punishment or 1-week punishment or anything like that. Because in the society it is a general perception that doctors are being taken care by the State Medical Council or that MCA with the doctors because these were the doctors who will be deciding the cases. So now with the level of punishment attached, so there is no option for the State Medical Council or EMRB or National Medical Commission to, they have to decide because the level of punishment is there. So we have to take, at a State Medical Council, being a registrar of State Medical Council, Delhi Medical Council, we have to take action. And of course, now the complaints against the doctors will be increased multifold. Because nowadays we are receiving the complaints, 35 to 40 complaints at Delhi Medical Council we are receiving against the doctor for the professional misconduct or medical negligence. And whether the negligence or not there, but these professional misconduct, which are aptly described in the National Medical Commission Regulation 2023, which at the moment are kept in abeyance. Maybe the one about the generic drugs, etc. or so, why they are kept in abeyance? Because IMA, DMA or medical association are taking credit for that, we have forced National Medical Commission or because ultimately it was the government who asked the National Medical Commission to put these in abeyance. But these are not in the, because of IMA, DMA or medical assurance, these are because of the pharma lobby itself. And I am, in this platform I can easily say that, and from at various medical assurance platform, I also said that this is because of the pharma lobby pressure only that these are kept in abeyance. Of course, when they come, let us see what the issue for that matter. Regarding some issues like confidentiality, because nowadays, previously the confidentiality is not under the professional misconduct or so. Of course, in the medical ethics, autonomy, beneficence, confidentiality are they part of the medical ethics or so. But confidentiality is level 3 punishment. That means if the doctor discloses the information about the disease of that particular patient to without his authorization to any other person, he can be charged with that level 3 punishment, that means his name can be removed for 3 months automatically. So in the times to come, it will be difficult because nowadays everywhere where the ICU or the patient is admitted in the ICU or put on the ventilator, whenever all the relatives, all the friends went to that particular ICU or ventilator, ICU or doctor concerned, and they get a relevant information for that matter. So in the times to come, it will be difficult for the doctors to disclose the information to that particular patient, because patient can allege that his information about the disease was informed without his authorization to such and such person, whether he's a friend or relative or whatever source. And we have, sometimes we got a genuine complaint for that. A gynecologist filed a complaint, a patient filed a complaint against the gynecologist who was a relative, that she informed that particular information to one of his relatives about the disease. So these type of complaints will be increased in the times to come.
So, Dr. Tyagi, just one question on, Manisha mentioned in her slides about the interaction of doctors, RMPs with the industry. And the language currently in the, regulation that has been kept in abeyance is pretty strict. How do you see this evolving, or will it just come as it is?
With what Manisha told about it is I think section 30 of NMC.
35.
Yeah.
Clause
With
35.
CPD, you cannot be directly or indirectly affected.
Yeah.
Madam, what this, ultimately this NMC regulation come, you will see there will be a difference for it.
I see. Okay, good to know.
And because no conference can be organized without the involvement of the pharma companies.
Right.
No conference. IMA, you have seen you can see the conference of the IMA or DMA or any medical association, because these are sponsored by the pharma companies, but of course there can be restriction for that, but you cannot ignore that pharma companies will not be there. Pharma companies have to be there, because ultimately
who has the
power?
Products, yeah. Also the products,
products.
Innovative products, etc.
Of course, there should be there should not be conflict of interest.
Yes.
With transparency.
Yes.
Some transparency should be there. So there will be some guidelines should be properly maintained, properly formed, so that if I'm going for a conference, I am not just going for that, taking the lunch, dinner, or drink for that matter, writing those prescriptions which are not mandatory. And of course, regarding that prescription, it should be rational prescription. Rational prescription should be there. And if we are working with the transparency, and honestly, I think there should not be any problem. And this, I am telling openly in this forum, let this NMC regulation come. There will be a difference in the section 35, which deals with the CPD.
Right. And what about the generic prescriptions?
Generic prescription, of course, but let the government assure that quality of these generic medicines are equitable with their counterparts.
Right.
Because if you are forcing doctors to write generic medicine, then it is the job of the government to see that there should not be. Why the hell there will be these pharma companies for that matter?
Right.
You stop producing that drugs.
Right.
Branded drugs. You stop producing branded drugs. Everybody has to force to write that generic drug.
Right.
So government should think. Government should decide what they want, because government is not decisive in this particular context regarding that. Whenever they feel that they write that generic drug should be there, it was in the MCA regulation, 2002.
Yes.
And it is 2024.
Yeah. And there were changes, there were amendments to it, as Manisha had mentioned. Yes. Thank you, Dr. Tyagi.
Thank you.
Is there anything else that you may want to add, and we'll let you go?
From this fora, I request all the doctors to just go through those NMC regulation 2023, because it will be a problem for doctors to defend themselves regarding consent. Because at Delhi Medical Council, consent is level 4 punishment. Level 4 punishment, if the consent is not proper, your doctor's name can be removed for 3 years. 3 years means, that means for 3 years he cannot practice medicine. And at Delhi Medical Council, because we receive, because we doctors think that a consent is just a piece of paper, a formality only. Consent, there is a Supreme Court judgment, Prabha Manchanda versus Samira Kohli case, which aptly describes that consent has to be proper and valid consent. Valid consent means if the patient is major and of sound mind, consent has to be taken from that patient himself, no other person can give consent. And at Delhi Medical, most of the time, in your family also, if mostly in the obstetric cases, when the cesarean is advised, consent is being taken by the husband or from the sister-in-law or from the mother-in-law, never from the patient himself. And if the consent is not from the patient, it is invalid. Your doctor's name can be removed for 3 years automatically if the consent is not proper. So my request from this fora, my request to all the doctors, go through those NMC regulation 2023. At the moment they are kept in abeyance, but maybe in a few days, months, they will come into force, and you have to be very careful because the number of complaints against doctors will be drastically increased, and action have to be taken because they are now, with every professional misconduct or unethical behavior, there is a level of punishment attached. So there is no option to defend yourself or State Medical Council or ethical EMRB can save you.
Thank you so much.
Thank you.
Yeah, we'll let you go. Thank you very much.
Thank you, because I have to go to Jaipur, and I'm directly going from this place, and there is a National Medical Commission program tomorrow at Jaipur, and I have been asked by the National Medical Commission as an expert. Thank you very much for giving me a chance.
Thank you. Thank you. So my next question goes to Dr. Sunil Khetrapal, Director, Association of Health Providers India. What are the ethical challenges faced by healthcare providers in their day-to-day practice, and what are the solutions to meet those challenges? Because that's a very important aspect that doesn't come through.
Yes, Krishna, thank you so much for asking such a valid question. At the outset, I would like to thank HEAL Foundation and AIMS for giving me this opportunity to be here among the esteemed panelists. And this is a very important session. We are talking of navigating medical ethics. So ethics is nothing but it is your morality and the behavior, what we do. And there are certain principles which govern the medical ethics. The most important and the first principle of the medical ethics is the patient, the respect for the autonomy of the patient. That means respecting and protecting the rights of the patient. You know, there are so many, rights I can enumerate. And second thing is, we are talking of the second principle is the beneficence. Beneficence, that means you will work for the benefit of the patient. You will not do anything wrong with the patient. And third one is the non-maleficence. That is, you will not do any harm to the patient. And you will ensure that once the patient is in the hospital, there should not be any adverse effects, any adverse events that happens with the patient. And the fourth principle for the medical ethics is justice. Like you will actually provide equitable, you will have equitable distribution of resources and provide equitable care to the patient without any, without any partiality or any injustice. So these are the four major principles we should keep in mind when we talk of the medical ethics. Based on these principles, now I would just like to talk about the medical ethics, the issues which surrounds around the doctors in day-to-day practice. As Dr. Girish Tyagi also touched upon the confidentiality. So first thing is confidentiality. It's very important that we cannot disclose the patient's medical condition without patient's authorization or without patient's consent, which is very important. Like, Sometimes, I have worked with various hospitals and I've seen that people, they talk very loose. In the lift, some staff nurse and some other staff people are there. अच्छा वो patient जो bed number उसको तो HIV है, उसका नाम लेके वो HIV का patient, positive patient है. So that is the breach of confidentiality. How can you, just announce it openly? So confidentiality, patient records have to be kept confidential, patient's medical disease condition has to be kept confidential, that is important. Number 2 is informed consent, which Dr. Tyagi has touched upon. I would just like to elaborate. There are 2 types of consent. One is implied consent. Implied consent means when Manisha has gone to a hospital in the OPD, paid the OPD fees to consult a doctor, that is an implied consent. It means she's agreed to, consult a doctor. And that is implied. There is no need to give a written or informed consent. Informed consent is taken in those conditions where you have to be explain the risks, the benefits, and the alternatives to the patient. And informed consent is taken in certain procedures, surgeries, and blood transfusion, and of course research is one important area where you need informed consent. So informed consent, most of the time, I'm also a principal assessor, NABH. NABH is the National Accreditation Board for Hospitals and Healthcare Providers. I go and assess the hospital. I see consent forms not filled properly, half filled, columns left blank, like name of the doctor is not there, name of the procedure is not there, what type of anesthesia you're going to give, that is not there. In my days, when I did my MBBS in 1986, we used to have a common consent for surgery and anesthesia. Nowadays, we have a separate consent for surgery and separate consent for anesthesia. In anesthesia, you need to mention the type of anesthesia, the name of the anesthetist. Same way, likewise, in the surgical consent, you need to write the name of the surgeon and the surgical procedure. So informed consent, and 50% of the medical negligence cases, please mind it, 50% of the medical negligence cases are consent related because they are not taken properly. Documentation of informed consent is very important.
Thank you.
Yeah, thank you.
Thank you. Thank you. So there is one other issue in the mix now. There is a new law from 2023, the Digital Personal Data Act. So the consent will also be guided by that act, which will override some of the consent requirements. You have to up the requirements. So
That's right.
Hospitals and others have to actually comply with the new regulations once they come.
Yeah, absolutely.
Yeah.
Agree.
Thank you. Thank you. Okay, so I move to Dr. Rajiv Gautam. Dr. Gautam, Horiba is a multinational company, and in that context, with your global experience, what are some of the best practices that you have with the industry RMP engagement in your institution?
Thanks, Krishna. Let me change little topic from ethics of these things to come to what a company can do. Of course, this is the government can do or the doctors can do, what from the industry can do. There are 2 types of products, regulated and non-regulated. Okay. So I think India is following the international norms of getting into regulations. If you see, you must have heard class 1, class 2, class 3. So internationally, they have only 3 classes based on the risk factor to the patients or to the consumers. But India, we have 4. There is one risk and one is high risk. Okay, so we are following that. Okay, and accordingly, there is the ISO 4385 something there. Everybody. So I think we have the norms internationally. Norms I think is coming to India. How much we follow and how much we don't follow, that's a little bit, but there is a coming back to the industry, I think all the products which we are producing, which is GMP laws or it is US FDA, which we have to export, so everything is comes under regulations. And just tell you to the audience, 2 years back, you can bring any equipments from the market to India, you don't require any license. It was, yes, for anything consumables you require license, for instrument you don't require any license. But now last 2 years, also you require a license for that. License means once this is also regulated, all these things, validations, everything is there. So I think industry, good industry, which is the multinational global industries are following these international laws, and India is as far as I think to the international global things, and our quality is also thing. We are exporting so much on that.
Yeah, Dr. Gautam, the question today, linked to the navigating medical ethics.
Yeah.
Say for your medical devices, once you need to kind of, acquaint doctors and hospitals about them, what are the modalities within which you do that? Do you have a set criteria as to how that interaction is going to happen?
Yeah, it is based on the validation, what are the validation criteria we have and what are the norms we have. So we meet all the doctors who are the consumers, and we just educate them in
Right.
that thing.
So in the context of the NMC regulations,
Yeah.
which has been now kept in abeyance,
Yeah.
the clause 35 now would prevent you from doing that
Yeah.
if it were to come as it is.
Yeah.
So that was the matter of discussion, because I think for medical devices, some drugs, innovative drugs, but certainly for medical devices, it's essential that you kind of help doctors understand how your medical device actually works. So would you want to kind of comment on that clause 35?
It's NMC norms that's coming here, but globally it is different type of norms are there. So it's education for all the medical practitioner or the users or the technicians. So they have been doing it. So we will not do one-to-one, or we don't do everything, but we will definitely do like education sessions like this. Yeah. Definitely, it has been doing globally. Globally we are doing with other companies, as Horiba is doing. We will continue to do it here.
Thank you. Thank you. So I move to Mr. Atul Sharma. In fact, on the same theme. Do you think that industry RMP interaction is critical for developing new therapies, and thus in the interest of patients? Can you share your views on this from your experience?
So first of all, thank you very much, Krishna. Thank you, HEAL Foundation. Thank you, AIMS. First of all, we need to understand what are we doing collectively as an ecosystem. There are people known as patients suffering with disease A, B, C, D, or likely to suffer. There are innovators who are constantly in pursuit of developing new innovation to develop more effective, safer and shorter duration of treatment. And then other place you have the HCPs under the title, who provide and render the services around the patient to treat them effectively. Now what we are talking about is an engagement between somebody who is constantly innovating and the person who is providing the service to the patient. So that audience is the same. Collectively, both of them trying to alleviate the suffering of the patient or achieve the desired outcomes. Now, as an innovator, you are constantly doing research or constantly innovating. You are generating new data. You are bringing like tremendous amount of paradigm shift, the way historically diseases were treated and need to be treated now and possibly can be treated. After generating those evidences, you need to then engage with the stakeholders, like which could be right from like research. I'm not touching that clinical development part, phase 1, phase 2, phase 3. After that, the next level of that regulation is that how do you bring the new innovation or new intervention impacts the prevailing treatment guidelines. And the treatment guidelines, so it comes like from the top, so you need to engage with the people in the medical fraternity, say something like, right, starting from US FDA to the state FDAs, or to other medical fraternity or medical organization to adopt to those guidelines driven by the evidence, not by assumptions. So that's an engagement. Without engagement, that innovation can never ever come into that practice. Now, after achieving that, the next thing comes like the patients are treated not by the policy holder, which are a handful of the people, by a large universe of HCPs. And what exactly has changed, which is constantly changing. If you look into medical guidelines, treatment, the new classes of drugs and new intervention happenings, they need to be then subsequently disseminated through various type of engagements, which could be, say, giving introduction into Congress and conferences, into, say, focused group meeting, advisory board, taking inputs from them, like what exactly need to be changed. So these are various level of engagement. Even it goes at the grassroots level where the sales force of any innovator company or pharma company will engage with the large universe of treating SCPs on the ground. Now, when I look into, say, my kind of like background, and give some quote couple of like practical examples. So way back, say, in year 2000, globally the asthma and COPD guidelines got changed because the GINA used that evidence, but the historic guidelines like were so very different, like very rudimentary. So you have to work to have those new national guidelines or national consensus document. Then only after those endorsements, the large universe of pulmonologists or GPs or chest physician can treat the patient in a different way, which is superior, shorter and faster. Yeah. And I will put like one more example, like, so this is 2000 and then 2008 we worked with specialists to develop the diabetic foot ulcer national consensus document, which was non-existent in the country. And so it goes on. Yeah. So next thing like which comes like when we are looking into government regulations, I don't think like that look like very well thought of. That
Thank
what
you.
are these two guys doing or these two group of people are doing it. It looks like more policing. And it looks like the value which collectively these two people create in the lives of the patients are viewed as criminal.
Right.
And that attitude towards like engaging with the professional who was into invention or innovation at one place. And second part is rendering that services to the patient who are actually suffering, not artificially suffering. And that is being viewed as like criminals, and the law looks like very, very rigid, and they don't look like somebody has actually applied a thoughtful thinking to deal with the two different kind of like professional people in the space of health.
Thank you. Thank you. I think, in the end, you really summarized it very well, that the NMC guidelines, which has been kept in abeyance, looks like, they are being a nanny state, nannying, professionals who can think on their own. But I also feel that self-regulation is always the best regulation, okay? So if there are, parameters within which the profession and the industry agrees to kind of work within, there is no need for an NMC guideline to come up so hard with punishments to the boot. So I would now ask and open this question even to the audience, is that what is it that one thing that the profession can do, doctors can do, and what is one thing that the industry can do to keep this peace and not need a Damocles sword over you like the NMC guidelines. So I will start with, Khetrapal, and then just go. And could you just make your, because we have about 7-8 minutes, so could you just make it like in a one-liner? First, doctors, self-regulation, and second is, what can industry do?
First thing is when you talk about the self-regulation, self-regulation comes by the ethical professional conduct.
Correct.
So this is one line.
Correct.
Ethical professional conduct. And number two, for the industry means all the stakeholders, which not only pharmaceutical, but the medical devices, and there are various other industry stakeholders, that they should collaborate. I mean, because it is, nobody should work in silo. And they should collaborate, always keeping in mind the patient on the top priority.
Right.
Patient should be at the center.
Right.
We are all part of healthcare ecosystem.
Correct.
In the healthcare ecosystem, patient comes first.
Right.
Right? So patient, keeping in mind, so whatever drugs we are manufacturing, the quality has to be ensured, generic, whatever we are talking of. So we have to work cohesively in a collaborated manner so that patient gets the best of care.
Thank you.
So
You put it beautifully. Manisha, one line each, okay? One for RMP, one for industry.
So
Short.
for RMP, as you know, we already have it. Professional integrity and patients' interests should be the focus. For industry, maybe they can act in a more transparent manner and open to kind of audits.
Audits
if
and
needed.
disclosure.
Yes.
Yeah, fantastic. Okay, for you.
I think Manisha summarized very well. So the morality comes like when I see myself, if I'm a patient, what is the way a doctor need to treat me? What is the way a device or a pharma industry need to deal with me, whether it is a pricing, quality? Because I'm in a situation like where I'm very, very fragile. Am I being taken care of with dignity or I'm
One
being
line.
exploited?
One line each.
So that's all. So self-regulation means that is what need to be understood by
We've been
all
also told.
stakeholders. Yeah, please.
Sorry.
Over to you.
Okay. Dr. Gautam, quickly.
Just say, it's all ethics aside, it has to be commercial viable for industry as well as this. Until unless commerce not it come to the picture, it's not going to work. We can say anything on this diocese. See, if patient is not paying, nothing is going to be ethical. So it's the commercially viable we have to think, whatever it is.
Thank you. It's a different view. So because we started late, I want that indulgence to put this to the audience. What do you think could change for the doctors if they behave differently, not to have very strong regulation, and what can industry do? Anybody? You can just put your hands up, identify yourself, and we'd like to hear. Because this is not a legal question. It's a commonplace. We go to a doctor all the time. We read about it all the time. Anybody? Okay, so I kind of close with that because I don't want the second bell to come. Thank you very much. You had a very stellar, stakeholders here speaking to you. Please feel free to contact them if you need any clarification. I hope this helped you. Thank you very much.
Thank you so much, Krishna ji. And now I will request Mr. Dhananjay Kumar to please come on the stage and please present token of appreciation to our speaker and moderator. So about Dhananjay ji, Dhananjay is one of the oldest health journalists of the industry. Thank you so much, everyone on the dais. Can we have the video, please? Thank you so much. So after this session, we have the quiz coming up, and participation in quiz will, make you eligible to win a smartwatch tomorrow. So I request you all to do participate in the quiz after this session. Moving on to the next session. Next session we have on empowering independence, exploring assistive care solution. For this, this session is chaired by Dr. Professor R.K. Srivastava, ex-chairman, Medical Council of India, ex-director, Journal of Health Services, Government of India. If I request sir to please join us on the dais. The panelists for the session are Dr. Ashu Grover, Scientist F, Deputy Director General, Indian Council of Medical Research, New Delhi. Ma'am, if you can please join us. And the third panelist for the session is Dr. Chandrakant S. Pandav, Padma Shri Awardee, the former HOD Community Medicine, AIMS, New Delhi. Sir, if you can please join us on the stage.
They want it to be aligned with the जैसे भी How do we go? From here?
Yes.
No?
Yes.
Good afternoon and good evening. We are late. So we are few left. This particular session, the topic has been told to you. It is for those who want assistance in life, particularly for their healthcare need. They are usually old person. They are person who are hospitalized for long duration on account of some type of NCD or NCD related problem. They are those persons who unfortunately are inflicted with some type of congenital or acquired disability on account of multiple reasons. But if we look at the numbers globally, it It is a very huge number. Geriatric population is increasing, NCD is increasing, disability is increasing, and collectively in developed world, in HIG, it constitutes about 30 to 40% of the overall population of any country, and in LMIC, it is considering round about 18%. So it is a huge population. If you look at India, it is about 140 crore and 18%. In numbers, it is equaling to the number of many countries. So the problem is huge. Now the need, if you look at, I think good number of persons sitting here are using specs. They are assistive technology. Dakshav has come here, he used a wheelchair. It is an assistive technology. He used a support, human support. It is also an assistive technology. There are ramps which are provided. It is a facilitatory arrangement for utilizing maximum from assistive technology. So assistive technology are needed everywhere. In hospital you see stretchers, walkers, they are all assistive technology. You go to a person who is hard of hearing, elderly person, putting something in the ear, say, what is this? Sir, I am not able to hear properly, but now I am fine. So, unnoticed assistive technologies are spilled over before our eyes, and we do not realize that they are our essentialities of good living. But when we suffer from some type of demand, we realize that it is there. That is how World Health Organization started its work on the assistive technologies. 2016, they came out with a priority list of 550 assistive technology bundles. Like wheelchair, one wheelchair is one item which has got 5, 6, 7 type of wheelchairs. Some are folding, some are non-folding, some are can be put up in a car, some cannot be. So these 50 bundles have got about 100 items. And this was not coming out from the drawing room or air-conditioned room. It was after the global consultation and the field visit from the end users, seeing the need assessment and thereafter finding that this is the priority setting and this is how they did. ICMR started the same exercise 2016 and they came out with a list somewhere in 2017 which was quite big, about 380 or 80 plus some items which were also put up in 9 bundles. Then the unfolding started because at the end of the day, if you have a list and you are not able to provide it through the system, it is useless. If I cannot offer a stick free of cost, if I cannot offer a crutch free of cost, if I cannot offer a normal glass free of cost from our system. System does not mean only health system. System means all systems. Systems in the hospital, government, private, system from the vendors who are selling it, systems coming for the disabled, everywhere. But there should be a system and there should be supply. So unless and until put all these things into the supply chain, it is of no use. So ICMR started the priority setting exercise by using a Delphi method, creating a funnel, and ultimately landed up in creating 20 or 21 bundles with about 30 to 35 products which are needed by Indians, Indian hospitals, Indian populations, which are preferred by the Indian manufacturers, which are available but of not high quality, which does not have export potential, and which are in short supply, resulting in recycling. A wheelchair being distributed to a disabled person in a camp, Next week you will find the same person sitting in another camp and asking for another wheelchair. This is the recycling. So all these things were put up in the need assessment. Consumers, manufacturers, all stakeholders. And this 30 list was finally released by the, I think, DG ICMR somewhere in 2022 or 23. Now, step 2 is that they should be produced in India. So the stakeholder consultation, which started with the design department, Bureau of Design, and ICMR and Niti Aayog, they wanted to create world-class design standards so that our manufacturer indigenously produce it, give employment to our workforce, utilize our raw material, and give a quality product which is globally compatible, globally competitive, at least for Southeast Asia. That was the task. This is working. And I think Honorable Prime Minister as well as Niti Aayog, they are quite concerned about it. Ministry of Social Justice, Ministry of Health, they are all converging and trying to create it, a system. But manufacturing the things is not the only thing. There are other things. Suppose a wheelchair is to be used by a person who is suffering from a paraplegia. He cannot lift himself. He requires a different type of wheelchair. Suppose another wheelchair is to be used by a person who has got good sensation. He requires a different type of back seat rest. Suppose there is a person who is using a glass or specs, who is having a type of aphakia, he will require different type of. So somebody should be qualified to prescribe for it, and it requires a training, certification. So we started working with the various training organizations and other organizations which are certifying it. So all these things are taking place in consultative mechanism with, say, WHO has started a training program which is known as training for assistive product. There is multi-module training. India is a partner for it. We have started it in India and Nepal. Then there is a rapid assessment of the actual needs field. So there are softwares which are available. We are working on that also. And we are trying to disseminate the things in all the region in the country. In this context, I felt it necessary that our friends who write about us, they should be told a little bit that these assistive products are necessary because they improve the quality of life. They should be cheap, they should be of highest quality, they have got a very high export potential because all 11 countries in the Southeast Asia are deficient in self-manufacturing. And lastly, high-end 20 assistive products which are available in India, which are used in India, are 90% imported. You will be surprised that a wheelchair which you must have seen some person, some good international scientist, Mr. Hawkins, using a wheelchair which was totally computerized, having all the software solutions. He was using a synthesizer, voice synthesizer. This wheelchair was costing approximately the cost of the best class, world class SUV. In India, such type of high-end products which are assistive in nature are all imported. And the cost, the repair and maintenance is not here. So once purchased and it is damaged, it is lost. So for self-sufficiency, for economic dependence, all these things need to be manufactured in India. Luckily, Government of India has made a policy that Make in India is our imperative. They have got a preferential procurement policy that class 1 and class 2 product will be preferentially purchased if they put their quote their cost against the tender. So there is a preferential procurement also. This enabling environment is here. Now in this enabling environment, my dear friends who are here, who belong to public health, who belong to the journalism group, they are the persons who are the communicator between what ICMR and what Government of India is doing and what public should know. So that was the main reason I requested HEAL Foundation to have some time for us also so that we can talk about it. Now I will request first of all the end user, his experience, to say that what I am talking has got some sense or it is absolute nonsense.
Thank you very much, everybody. There is an evidence that if you clap for 2 minutes, the energy level in the hall will rise. So can I ask you to clap for 2 minutes, please? This is an evidence-based medicine. 2 minutes के लिए तालियां बजाए तो energy level in the hall increases. This is evidence-based medicine. Now, sir has asked me, my dear friend, हमारे esteemed colleagues है, हमारे गुरु है, उन्होंने बहुत straightforward सवाल पूछा मुझे. I've been using the wheelchair for the last 3 years. I got Parkinsonism syndrome, which is a different story. I'll share on some of the platform. Sir, लेकिन आपने एक चीज़ बताई शुरू में. We don't consider glasses as a assisted device. It's so common. मुझे नहीं पता था.
I said that.
I know you said that, and I want to appreciate for you saying that.
We use glasses as an assistive product.
Yeah, we take it for granted, glasses. So I got my glasses in the 3rd semester. It's a gift of the MBBS.
But is it not assisting you?
It is very much an assisted device, but we don't take it to be assisted. It's so common and so widely prevalent.
Yes.
Now, that's number one. Number two, in India, there are 27 million people who require assisted devices. 27 million, sir, आपने सही बताया. That is the population of Australia, 27 million. The number of wheelchairs required is 1 million. 1 million wheelchairs. And my experience for using wheelchair in public domain for the last 3 years is very, very depressing. My journalist friend, please note, I go to Niti Aayog fairly regularly. And you'll be surprised, sir, there is no wheelchair there. Niti Aayog of the Government of India, which makes the policy for the whole country, there is no wheelchair. Number one. Number two. Number three. When I want to go to the washroom, my All India Institute of Medical Sciences, there are very few places where there is washroom for the handicapped people. सोचते ही नहीं है. जब तक आपका मुंह दूध से जला नहीं होता तब का आपको याद नहीं आती. Fourth, I travel a lot in spite of being so-called handicapped. My colleague Balwant is there. Where is Balwant? Jesse is there. There is not a single petrol pump in the country. I've traveled widely from north to south, east to west, which has an assisted washroom. And actually the quality of washrooms are so dirty, it's a disgrace and a shame. हम स्वच्छ भारत की बात करते हैं, ये असच्छ भारत का सही नमूना है. All the petrol pumps. So basically, your entire thinking changes, your perspective changes. जब तक आपका नौबत नहीं आती तब उस दृष्टि से आप सोचते रहिए. Sir की अलग बात है, that's his discipline. That's why he's been able to think sensitively on this issue. So my humble submission to all of you is that please take handicapped people, whether visually or by using earphones calipers, crutches, wheelchairs, trolleys. Please take them with sense of responsibility to assist them in terms of whatever they are doing. After, we are also part of the society. So, sir, my impression in terms of attitude towards the handicapped people is extremely, extremely non-existent in India. That's a matter of shame. And I'm saying this on a public platform from the All India Institute of Medical Sciences. The country which has done exceptionally well in looking at the needs of the handicapped people is Netherlands, Holland, Germany, Sweden. They take very good care of the handicapped people. So with these words, sir, thank you very much for the opportunity. And I want to congratulate you and express my deep gratitude for introducing this very important session. क्या आपने बनाया, हम आपको धन्यवाद देना चाहते हैं।
शुक्रिया शुक्रिया, मैं तहे दिल से आपका शुक्रगुजार हूँ जो आपने अपने फीलिंग्स एक्सप्रेस की ना, इसकी बहुत ज़रूरत थी। एंड यूज़र के बिना कुछ नहीं है, एंड यूज़र के एक्सपीरियंस के बिना कुछ नहीं है। आप कितनी इनोवेशन कर लो, कितनी नई नई टेक्नोलॉजी ला जो, कितने मैन्युफैक्चरर ले आओ, जब तक हमारा एंड यूज़र उसके इस्तेमाल करने से हैप्पी नहीं महसूस करता, कंफर्ट महसूस नहीं करता, बेटरमेंट और क्वालिटी ऑफ लाइफ नहीं महसूस करता, तब तो एवरी डैम थिंग इज़ वेस्ट। बट साइमल्टेनियसली for a developing or so-called developing nation who is aspiring to become a good economic force in the world in future as well, there are areas of actions which need to be prioritized. So I have got Dr. Ashu here. She is a very senior scientist, and she is heading the delivery division. So the products which are ready, they must reach to the masses. She is heading that division in the ICMR. And ICMR is spearheading this particular subject of assistive technology for last 7 years to throw some light where we stand vis-a-vis the West.
First of all, a very good evening to everyone, and respected my mentors, teachers on both the sides. I really feel proud to be sharing this stage with both of you because I have learned many, many things from my studentship and till today. We get a lot of lessons to be learned from my left hand and my right hand. And a very big thank to the organizers for putting forth this agenda and inviting Indian Council of Medical Research, which is the only research body for the medical fraternity and for undertaking the health research agenda for the country and giving the good outcomes for that matter. As said by Sir, that I'm heading the Division of Implementation Research, and I think this is the thread which comes at the end of identification of the priorities. This is the thread which connects the research with the common man. And through this, and this has been done very recently at ICMR through undertaking various reforms with our current Director General, Dr. Rajeev Bahalji, and who has been instrumental and so thoughtful in identifying that how the country level reforms of Indian Council of Medical Research would be required. So there are the 4 major domains where the extramural research program of the ICMR is currently ongoing. So one is the discovery research, another is the development research, third is the descriptive research, and fourth is the implementation or the delivery research, which is being headed by me. And that is how that I'm here, that how to take the products which is required for the people with functional impairment, improving their quality of life, to the end users in a more efficient manner. So in the whole process of any product, you have heard many, assistive products here, like we have the spectacles, we have the sticks, we have the canes, we have the hearing aids, we have the hands, we have the clutches, and many, many, many things. And the life doesn't move forward if you're not using any of these products for those who are having in the need of such products. But who is going to take these things to a common man? So you must have heard of the program under national program under prevention and control of blindness, right? So that's the one national program. But under that program, we were, that whole program encompasses around distribution of the spectacles to those who need the, glasses with the school children, or for that matter, even others also who are myopic or who are presbyopic or who need the spectacle aids for that matter. So under the program, this is a good program, but it has certain limitations. So we need an evidence that whether this program, whether these spectacles being given to the end users, to the beneficiaries, have they ever been consulted that what level of glasses would you be requiring? What is your size? What is your requirement? What is your number? Right? So this is one example that there is some certain kind of mismatch between the good products, good evidence, good models which can take the product to the user, in this case is those who require the spectacles. So in that moment, what happened that if you go to any of the schools under the program, there will be heaps of spectacles lying in the healthcare facility or in the schools, which is yet to be distributed among those end users. So this is really a situation which we really need to think about it, because somewhere we are failing in implementation of our, the findings, the evidence in a proper manner. Another example I can give you of using the hearing aids, right? Under the National Program for Prevention and Control of Deafness, NPPCD program, we have been working very hard that under the program we need to address the delivery or availability of the hearing aids to those who are using it. But have we never thought of that, what is the good product, what is its availability, what is the cost of this product, whether it is acceptable to the user or not, who will do that? So this is the area where Indian Council of Medical Research has been working since long and has tried to put up into more implementation mode through evidence generation that no, this is the product which is good, this is the product which is optimum, and this is the product should not be used. So for that mechanism, I would like to put forth to the audience and other media partners that to undertake this exercise at ICMR and Department of Health Research level, we have the whole system of health technology assessment. And I just want to put it like that. So under health technology assessment, there is a whole wing who takes care of that, whether this product, whether this device, whether this intervention, whether this program needs to be taken up into the national program or not. So it has to be HTA. And that HTAness includes the accessibility, the availability, the affordability, and its economic evaluations, whether we introduce this program, this intervention into the program, whether it will be cost effective or not cost effective. So ICMR has done lots of efforts to establish this health technology assessment part, not only for the products related to which require the assistive technologies, but for other such parameters as well. For example, the digital thermometer, the pulse oximeter, and some of the devices which take care of the sickle cell disease, or many more things are coming up. So basically, ICMR is an evidence generation body, sir. So through evidence, if we are moving in the right direction, that whether the spectacles are cost effective, they are accessible, they are affordable, whether the wheelchair is customized, we can't with no size, even no all shoe will fit to all the fit shoe. So we need to put up a right environment where we can generate evidence that whether this will be customized or not customized. We cannot distribute the products like other ministries have been. Another thing before I end up and say that we really need the collaborations. We cannot work that, okay, this is only Indian Council of Medical Research and we will not work with the Department of Rehabilitation, we will not work with Department of Social Justice, and not work that what are the priorities of the Niti Aayog are there. So we need to have more and more collaborative efforts in this direction to give an evidence-based solution to the national programs. And for that matter, we will definitely require the support of the audience like you, who can take our messages to the policymakers and to the end users. Thank you for giving me the opportunity once again.
So what we wanted to say, we have said. How much it has gone down to the audience, I don't know. But one thing I am sure, that you are our eyes, you are our ears, you are our messenger. If you will know right things which are happening in this country, so that the overall health system, including the research, including the delivery, including the persons who have been affected with disability, everybody, if you are rightly informed, you will rightly write it in your columns, you will rightly speak it in your various channels, you will rightly debate it on. The key message which I can derive from the various type of experiential research and the system development happening in the AT sector is that we are moving ahead, may not be with the pace which is required in research. We are moving ahead with little bit faster pace in designing, developing and partnering with the manufacturer and the various authorities. We have got a system already moving forward for teaching, training, capacity building, but we are lacking in creating a right attitude of the society towards those who are using such type of assistive technology. And mind you, we have started living longer. There is a very, we talk evidence. The global evidence says that 60 to 70 you need one assistive technology, 70 to 80 you need two assistive technology, and thereafter as number if you survive. These are the figures of the West. But what will be the figure in India, I don't know. But the general impression is, normally when you retire, you are having a SPECT. Some of us have got one knee replaced. Some of us have got one stick using. Good number of us are using intraocular hearing aid. So the visible urban society is gradually becoming more and more dependent as they advance in age. When our lifespan will increase and we will reach to the what normally the Westerns are living, our dependence will grow. And when it will grow, our expenditure will also grow. And when our expenditure will grow and our economy will not grow proportionately, we will be import dependent. And when we will be import dependent, it will exploit our economy just like petrol is exploiting us. So we are working with that particular mission that India becomes self-sufficient. We can make this product in India, satisfy 90% of the need of our larger population for this type of product. and we need positive messaging from your side. So that is all I want to summarize and share with you. Thank you very much. If there are questions, please do ask for it.
Is there anybody from Times of India here? 4 days back, I read the news in Times of India, flight coming from New York to Bombay. There was a couple who were 80 plus. There were 30 passengers which were required wheelchairs. Only 14 were available. That couple decided to walk. The husband died at the immigration counter. This is the kind of sensitivity we show to our people.
Yes, sir. I 100% agree. But this is one reported news. Unreported news. Unknown news. You know it, they are happening. But they are not able to reach to you. So it is a gigantic problem. If somebody is dying due to absence of a wheelchair in the airport, for me, it is a crime committed by the authorities. It should not happen. Okay?
Thank you, sir. It was really an eye-opener session for all of us. And now I will request Dr. Rajiv Gautam, President Horiba India, to present token of appreciation to our speakers of the session. Can we please have a group photograph also, please? Thank you so much. Can we have a video of our partner?
इस पल को मुमकिन करने के लिए अबीर ने पहले से ही शुरुआत कर दी थी।
ये पल सच हुआ ये पल, गिन गिन के बुन के सजा है ये पल, मन में जुनू सा लाता ये पल, खुद से किया जो है वादा ये पल, जज्बों को नया रंग दिखाता ये पल। ओ ओ ओ ओ पलकों पे सूरज सा उगा ये पल, मानो रुक सा थम सा गया।
और म्यूचुअल फंड से शुरुआत करना समझदारी की निशानी है।
Thank you. Now it's time for the much awaited quiz. So Mr. Hardeep from my team is standing on my right. You can take the scanner from him and scan to participate in the quiz. 5 lucky winners would be given smartwatches tomorrow. So I'll request you all to come forward and participate in this quiz. So this will be on the sessions that we have had till now. There will be second quiz after the next 2 sessions, and the third quiz we will be organizing tomorrow. and the overall result of all 3 quiz will make you eligible for a smartwatch tomorrow. So moving on to the next session, we have a special talk on digital innovation in clinical communication, comply with Data Protection Act 2023 and other use cases. Mr. Rohit Singh, Managing Director, Feedback Medical India Private Limited, will be giving his insight on the session. Please, if you can join us on the podium, please.
Distinguished dignitaries, ladies and gentlemen, my name is Rohit Singh. I'm Managing Director of Feedback Medical. It's my honor and pleasure to be speaking in front of this august audience today. What I'm going to talk about today is about a digital innovation in medical imaging and clinical communication technology. You will see a lot of the use cases of this technology in the current era. Specifically, where I am going to focus more upon is about how this is going to be relevant in the case of secure clinical communication. The area where the patient's data safety and privacy comes into the picture, where not enough attention has been given so far. But we all know that Personal Digital Protection Act 2023 has got Parliament approval and President assents last August 2023. And the executive rules are going to be out. So let's see how this digital innovation in clinical communication can solve the problem of this secure clinical communication in the patient's cases. It's not moving. Excuse me, slide is not moving. Sorry, I'm talking about technology and then some technology issues. Will it work? Yeah. So before I get into detail, a very quick overview of this company, Feedback Medical. It's a more than a 2-decade-old London Stock Exchange listed company headquartered in London. This is specialist medical imaging technology company, and we pioneer in producing world-class medical imaging and clinician communication software as a medical device. And over the 2 decades, we have processed millions of patient data, including specialist data like DICOM radiology images. There are few products, key products that we focus upon. The BLIPA, which is I'm going to talk in detail. This is about how this can connect the medical professionals, the securely and safely. And the Care Locker is about, the health locker, but in a very different way, that how the DICOM images, the radiology image, these images also patients can access. And the Feedback Connect is a very innovative digital disruption where this software can help to push the radiology images from the remote areas where broadband connectivity is not there, but the mobile communication is there. So over the mobile communication, those images can be pushed to the cloud where the screening of those images can happen. And then we had two legacy product, the TexRad, where over 2 decades we were pioneer in producing this software for global medical research organizations in the case of the oncology research. When it comes to the clinical communication, we need to understand there are 2 important things that any clinician want to have. First of all, they want to take right and fast clinical decision. And for that, they want to have anytime, anywhere access to all the clinical data, including the radiology images and all. And at the same time, they want to collaborate with the clinical team and the patients and the fellow nursing staffs and all. But how they do it that currently? Currently, if you will see that there are multiple options, IT systems, these are available from hospital standpoint, whether there is a radiology information system, PACS or hospital information system and many others. But many of the times what happens that because of the relative complex nature of these applications and less intuitive nature, many of the times the doctors, clinicians, they tend to move to use the public messaging platform like WhatsApp and all. Now what happened that no one can deny that whether someone is running a clinic, hospital, or diagnostic lab, the communication is key for the productivity and for everything. But the moment they start using this public messaging platform, the risk to the patient data safety comes up, and most importantly, with this Data Protection Act coming up, this is in a clear non-compliance as per the Data Act regulation. So let's understand how this creates a non-compliance. Just few things from a Data Protection Act standpoint. In the healthcare context, when you talk about the personal data, these are the health records, these are talked about, and data principals are essentially the patients to whom those health data records they relates, and data fiduciary are the hospitals, doctors, and the healthcare organizations. If you look into the definition of data processing, this is quite wide and quite varied. This essentially covers anything, everything that you can think of, including storage, transmission of information over the electronic media, and everything will be covered into this data processing. From business's point of view, the important thing to look into it, that as per the Act, the non-compliance could have a monetary penalty up to 250 CR and more in some cases. So what this Act asks for? This Act asks for 4 key things: consent, redressal, privacy, and safety. Now, as part of consent and redressal, one need to process health data after disclosing the purpose and receiving the consent, and need to delete that data after the purpose has expired or the patient has withdrawn the consent. But if you look into the public messaging platform, the basic consent management process is not available, and because data is stored locally in the mobile device, it is not possible to track or identify the data with respect to the respective patients. And it is very difficult to delete that data if consent is withdrawn. Likewise, in the case of privacy and the data security, the messaging platform, first of all, they are not password protected. So anybody can access to that information if your mobile is left somewhere, unattended. The other thing which I talked about, because it's a local phone storage, so it's prone to data loss or the cyber threat. And again, the audit trail cannot be established because anyone can delete the data if they require. Last but not the least, even these apps on the background sometimes share the data with the other applications. And this is not just about India. This is a global concern. All over the globe, the regulators have started now looking at it very seriously. Recently, in the UK Information Commissioner Office, they issued notice to a couple of NHS hospitals for using the WhatsApp for the clinical messaging, clinical communication purpose. So here this digital innovation comes, where the secure clinical messaging platform, which is compliant with India's Digital Data Protection Act, GDPR, US HIPAA, and the only communication platform globally where it is regulated as a medical device for radiology, images, communication purpose. And today we are the only and the single approved supplier in the UK NHS hospitals for this technology. The use of this platform has helped in improving also the clinical efficiency in terms of response time of the clinicians to the various clinical data by more than 74%. Recently, we have also been quoted in the UK's All-Party Parliamentary Group Diagnostic Report as one of the case study and as a recommended digital infrastructure solution for secure clinical communication. As you can see with a couple of images over there, one can not only have a direct dialogue, but all the reviewing of the clinical grade images and including, the referral management and putting all the, the offline to digitalization of, any document it requires. In a very simple term, you can think of it as a clinical WhatsApp, something that can replace the public messaging, the WhatsApp that we all use. This becomes a single platform that the hospitals, healthcare professionals can use from hospital care to home care. And one of the very important thing is it can help in setting up a secure clinical corridor among the hospitals within the India and international in order to refer to the patients and, remote access to the clinical data and all. From compliance point of view, as I mentioned, it's a Class A medical device and compliant with all the global regulations and including the highest level of, the cyber security and information security, the standard. The few important things to note here as part of this technology, because it's a cloud-based, there is no zero device footprint, and no one need to share their personal mobile number. In the case of public messaging platform, one need to share their personal mobile number, but it's not the case here. It can link to the multiple hospital IT system across different clinical settings and pull the images from their PACS system, report from their RIS system or the lab information system or the various different system and bring it in front of the the clinicians to collaborate around that data with the clinical team. It's safe, obviously, and because it has an ability to also do the annotation over the radiology images and they discuss over the cases, one can do a multidisciplinary team discussions in a lot of cases. Because of this, the ability to access this remotely and collaborate with the team, it obviously increased the, the flexibility for the clinicians to operate. And one of the very important thing is, as a platform, this can host any latest artificial intelligence tool on its cloud, so that any outcome of those AI tools can then be communicated and shared with the clinical team to take a right decision in the interest of the patients. One very important use case where we also got the award from ISW Council for the best digital solution for rural healthcare, where we deployed this in one of the very rural cluster of the Odisha in one of the hospital in Khariar, where the broadband connectivity was not there. There only the X-ray images, X-ray machine was there, and through our software, the X-ray images were pushed to the cloud over the mobile communication network, where our partner Cure AI's, the software was there, and the images were screened for the tuberculosis, and the result alongside the image was immediately being accessed by the clinicians, and within the minute, the result was conveyed back to the, the hospital in the rural part, and alongside that, the clinical care started. So the X-rays, the images, which are generally very heavy in size and cannot be transferred without having a proper broadband connection, these things can be pushed through the, the mobile communication network. And we feel that this could be quite disruptive in terms of, the remote rural areas, tuberculosis, and, the cancer screening opportunities. The same thing applies on the oncology side of the things. We know that there are almost 300, the oncology centers which are part of National Cancer Grid, but a lot of those hospitals are in the remote areas. Some of them have different level of IT maturity in terms of, the different systems they use. And the way the things function in the remote hospitals, the radiology images and all, once the super specialist or the specialist intervention for the second opinion is required, sometime it takes weeks to months to get to the, the final diagnosis before the care treatment can start. And with this technology, all these remote oncology settings can be, connected. Immediately, specialist input could be come into the picture. The images will be in a direct access to all the clinical team members to take a decision and, the fast track the entire, the care plan. The another important thing is on the teleradiology side, the similar concept, that a lot of artificial intelligence screening providers have come up where the hospitals have started outsourcing their teleradiology capacity. But the challenge comes that when someone radiologists need to collaborate with the clinicians to discuss on certain queries or, to discuss on certain patient cases, currently there is no proper mechanism in place. And with this innovation, those things can, come in an instant, the clinical chat, the mechanism where all those images and all can be discussed. And one of the very important thing, even from the patient standpoint, the DICOM grade images can be shared with the patients and no, the printing of the films may be required, and it will again lead to the saving of the cost from a sustainability standpoint. Relief disaster management is again one of the key area where it's of interest to a lot of state governments and also, the NGOs and hospitals who are involved into that. In the cases of drought or, the floods where the remote health camps are to be organized, where the portable ultrasound or the X-ray machines are there. And again, the linkages with the hub hospitals are required to bring the specialist input around the, the patient cases to take a quick and, the fast decision. This technology is very helpful. Last but not the least, the public healthcare delivery system. I think many of you must be aware that in the public healthcare system, we still follow some bit of, the colonial, the working style where the UK NHS system works in terms of referral pathway. Though still there is a democracy in India that anyone can directly go to the district hospital or a primary healthcare or wherever. But in general, the referral pathway is where you have ASHA worker, then sub-centers, then primary healthcare center, then community healthcare centers and sub-divisional or district hospitals, and then medical colleges and those things comes. In many cases, what happens that because shortage of the doctors' capacity, and we all know that public healthcare is having more than 50,000, the doctors, the shortage. The doctors at the community health center or the district hospital may be looking at the patients who might be looked at the sub-center or a primary healthcare center level. But because of no, the proper referral mechanism in place, they are still working on the paper, the process to do that. There's a lot of inefficiency in the system. With this technology, this can help in pooling the capacity of the doctor and making that, the referral process, the streamline, bringing the entire clinical efficiency even in the public healthcare delivery. These are just some of the deployments in the, the UK NHS hospitals. So what I wanted to emphasize and where I need, the media friends' help, that I think more than 95%, the professionals in the healthcare industry are using, the WhatsApp for sharing the patient's information. I think it's a time, the regulators are also tightening their string. I think it's a time to create that awareness in the industry that they should start looking at a secure clinical communication platform, which is a win-win for everyone. It will save them from any potential monetary fines from the regulator. And at the same time, as a patient, we all have been patient at some point of time in our life, we will be more comfortable if our data is secure and, safe. And alongside that, obviously, improving the clinical efficiency, enabling the remote flexible working, and driving patient retention and the acquisition is all win-win for both from a business standpoint also and for a consumer standpoint as well. In the interest of time, I was skipping through the slides quite fast just to make sure within the time I completed. This is just a short video to give you a glimpse of what the fundamental of this technology is. Obviously, in a different use case, different aspects, that comes into the picture. I hope this will play. Excuse me. Sound will come.
Clinician. Bleeper is the essential tool for remote, secure communications between clinicians and teams. An easy-to-use digital medical imaging communications platform that enables clinicians to safely view and discuss imaging and patient cases at the touch of a button. Features include instant messaging and digital image annotation, meaning treatment discussions and decisions are shared instantly among teams. Remote access to superior clinical-grade medical images. Add and share comments with your colleagues. Make and share annotations directly on patient imaging. Smoothly and quickly manage patient referrals and get second opinions. Discuss cases and gain expert opinions, advice and guidance. Take clinical images to add to the patient record. Capture patient consent for any images taken. Add clinical information including test results and notes. Designed by clinicians for clinicians. The Leaper is the secure digital imaging communications tool of choice. At your fingertips, wherever you are, whenever you need it. Share the whole picture.
Thank you so much. With that, I'll close my talk, but I'll always look forward to answering any questions if anyone have. And in the coming days, whenever anyone would like to see a demo, I'll be more than happy. Thank you very much to listen to me patiently. Thank you.
Thank you for that insightful session. I would request you to please wait on the stage. And I would request Dr. Subhash Giri, Director, Lady Harding College, to please present speaker memento from our side to the speaker. So now we have a very interesting session on the role of AI in health writing, and all of you are the health writers. So how this AI, which has emerged, the ChatGPT and all, can help you write your health stories, and what are the benefits, what are the ethical boundaries that would be discussed in this session. So for this session, I would request Mr. Dilip Minhas, co-founder and CEO of the Health Presso, to please join us on dais. Along with him, I would request Mr. Pratyush Ranjan, Head of Digital Services, Multimedia, Social Media and Fact-Checking Unit, Press Trust of India. This session would be moderated by Mr. R. Shankar, President, HEAL Foundation. Sir, if you can also join us on the stage, please. Presentation.
May I request everyone to please come on the front seats, please, if you don't mind. Dr. Chavi Gupta, Vishwajit ji, please, if everyone can shift to the front seats, that will help us. We are going to have a very interesting felicitation of all our health journalists, influencers who have come here on the dais by very key dignitaries, as well as the awards program, which will start in next 20 minutes after this session. Please, if everyone can come in the front.
To set the context of the session, the first will have a short presentation from Mr. Dilip Minhas. Over to you, Mr. Dilip.
Yeah, sure. Cool. So I've been told that we only have 20 minutes. That's what happens when you are presenting last. Hi, everyone. My name is Dilip Minhas, and I'm the co-founder of Health Presso. And I'll be just thank you. So I'll just take a few minutes to take you through some of the developments that are happening in AI and healthcare writing. This is what we are going to talk about. I think most of you know you must be using some of the tools right now, like a ChatGPT or a Bard or a Bing, and there is a lot of talk that is happening around this. I think AI was already there in some form, but what has happened with these tools becoming free and becoming very, very mainstream, now people have started realizing that AI can do so much more. What we are going to really touch upon is what's the role that it can play, what are the ethical considerations. I think we have spoken a lot about the ethical considerations around use of AI. Especially AI very simply means that it's a simulation of human intelligence processes by the machines. So like, I think there was one gentleman with whom I worked around 7-8 years back who told me that it's very simple. How a kid starts identifying an apple is how AI starts learning. So once you show a kid apple for the first time, he might not realize it's an apple. But over a period of time, when you show it again and again, the round thing, the red thing, something with a small what you call it, on top, some color and identification, it starts realizing that this is an apple. And next time when you show it to the kid, it says it's an apple. That's how machine learning, as we keep talking about, is all that. This is what we have seen, especially when it comes to AI in healthcare content creation. The traditional processes that we follow are very time consuming, they are labor intensive, they are prone to errors. It's not that AI is not prone to error. If human beings are prone to error, it will get replicated in AI. But what we are seeing right now is that over a period of time, the AI processes are becoming very, very efficient. They are helping in more targeted delivery of communication, and you can create content for diverse audience in just one click of a button. So those are the kind of things that are happening. These are some of the advantages that are there. Increased efficiency and scalability that you can get. You can generate personalized content for diverse audiences, and there can be improved accuracy and consistency in the kind of messaging that it can create. There are few, of course, pros and cons that are there of this AI in healthcare content creation. Of course, the pros we have already seen. There is efficiency, scalability, personalization, and accuracy. But if we look at the con side of it, there are biases that can come. Because if you see, most of the data is today, whatever machine learning is happening, or as we call that LLM, like large language models that ChatGPT is created on, is taking a lot of information from internet and then getting learned on that. So if that data itself is biased towards a gender or a race or any particular biases that can come, it will start reflecting same thing. There are, of course, ethical concerns and data privacy. We have seen what has happened in the US, wherein New York Times has filed a case against OpenAI saying that they have been training their models on our news articles. So we need to be paid for that, right? And there is, of course, human oversight that is needed to make it sharper. There are, of course, ethical and regulatory consideration. I think Pratyush is here. He will be able to throw more light on that. We will learn about it in depth when we have Pratyush talking about it. I'll just skip some of the things. There are ways in which these ethical concerns can be managed or addressed. You can have implement diverse training modules or data sets from where the information is taken up. You can ensure there is fairness and inclusivity by ensuring that different ethical, different kind of community stakeholders are also involved. There are different kind of, and I think we have already covered that in depth. I will not get into the depth of what is the regulatory landscape, but I think this is becoming one of the biggest topics right now of discussion. How do you regulate AI? Where do you sort of put a full stop of saying, okay, this is what is allowed, this is what is not allowed, and therefore, I think not just India, but all the 214 odd countries across the world are trying to right now look at how they can regulate AI and what are the boundaries within which it can operate. There are certain case studies, but right now I would say its usage is there, but not many people are coming out. It's almost like diabetes few years back was there, wherein you have diabetes, you don't want to talk about it. Many people are using AI, but if you ask someone, no, I am only creating original content. That's what a lot of people are saying. So therefore, you will not see a lot of people coming out and talking about it. HealthPresso is one such platform. If we have some time today, I would definitely want to just show you a glimpse of that. My colleague Siddhant is here. Maybe he'll open that platform while we are discussing, and we'll have a look at that as well. How we are using AI to create content for health specific topics. AI in journalism is not just a buzzword for all the health media guys. So if you see, starting from Reuters to ABC to BBC to Guardian, most of the people are using it for news distribution, news gathering, news production, fact checking. So if you see that one, the categories that are mentioned over there, you will find that it is being used quite extensively in AI. In India also, with some amount of research that I was able to do, I could find that there are certain media outlets that are already using AI, especially for automated translation, to generate news articles summary. And some of them, especially some of the TV channels, have started using AI-based news anchors also, who are right now only giving weather news and something which is pre-recorded, which is not on the fly kind of a thing. These are very important 10 steps for AI adoption in newsroom that we can look at. I will not get into the depth of this. If you guys want, I can share it with the team. This was very interesting that I could get. These are examples of where an editor has corrected what AI has written and AI has corrected what an editor has written. So these are like very interesting case studies where an editor, where AI has written something like a miracle cure and remarkable results, and editor has said that we can tone it down, while editor has written something which was very, very generic, and AI has given a prompt saying, can we make it more specific? These are some of the AI tools that are available. I'm sure all of you are aware of these: chatbots, design AI tools, video, content, presentations. I think you guys must have heard about this news, Sura, which is the new OpenAI text to video. And I'm very confident that it is going to make a huge dent in the way today AI is being used, because you just put the text and it is able to convert it into a video format. This is how AI ecosystem looks like, very, very complicated. But if you look at it, starting from copywriting to creating presentations to looking at larger data sets and coming out with the information, everything is out there. These are three main ones. I have tried to sort of look at what are their strengths, weaknesses, and applications. ChatGPT, very good when it comes to writing content, and Gemini and Bing are very good when you want data to support that content. So a lot of people get it written from ChatGPT, then put it on Gemini or Bing. Gemini is the latest of Bard, which was Google AI tool that was created. And I can say that Gemini is even better than ChatGPT with my own experience of using it for last few days. So these were some of the things that I wanted to talk about. I will skip this. Thank you. Thanks a lot. Yeah.
You can make your presentation, and after that we'll... I was told that the time is very limited, and Ankit has kept an AI tool just underneath our chairs that if we move beyond the time, it will automatically eject us from there. So is that a hand for question, or? Okay, now, Pratish, you are in the media, of course. Now from what, I'll play the role of a devil's advocate here. So from what Dalip has presented, how do you think AI can be used by journalists? Because many people have come here who are journalists as such, can use AI in their daily reporting situation. Like an editor or the chief of bureau typically assigns a story to a health journalist to cover so-and-so press conference, or cover a unique procedure done by a hospital, and he or she goes out and comes back with the information. How can AI play a role at that particular situation?
It's a great question, sir. Thank you very much for having me here on this very important discussion. AI is a great buzzword these days. So I'll just go back some years back when you all started using smartphones, and then you started facing the issue of fake news. So everyone started, all discussions started happening on social media platforms. So one day you didn't have anything in your hand to discuss anything, as other day you have so many, 2 phones you have, sometimes people are carrying 3 phones and presence on all social media platforms, and information is flowing unfiltered. So that happened, and with this, the problem of fake news comes in. As AI, you just mentioned about AI. AI is like, we all are talking about AI these days. But we don't understand the very basic thing is that this AI is a tool. Artificial intelligence is a tool. If Google has created Bard or OpenAI has created ChatGPT, that means they have some data set, and you are giving the prompts to the machine to give you the answer. The machine is generating the answer on the basis of the information or data they have in their system. If they don't have certain kind of data in their system, they will not help you. This is not of your help. So if in our journalism, there are a lot of different kinds of stories we do. Sometimes it's a sports story, sometimes it's a travel story, sometimes it's very explanatory kind of stories. So it is like the AI is not, I mean, as of now, AI is not going to help you in all kind of things. As for example, just a few weeks back, I entered some prompts in Gemini. That is, I prefer Gemini over ChatGPT, and because Gemini has the data set, what it uses, like it's very recent, till recent times. So I asked I gave 3-4 prompts that there's some blast happened somewhere. It was just for the information purpose, and there's a blast happened in front of some metro station, and a few people injured, and fire tenders are on the spot, police reached the spot, and investigations are on. Just create a story in 300 words. It created a beautiful story. I mean, if I would have asked anyone to write a story on the desk, it could have taken more than 15 to 20 minutes time, but the machine created a story in just 10 seconds, 300 words. A beautifully written story, wonderful English, but what it did, it actually gave me the data of such kind of blast happened in Delhi in the last 5 years, and that was false. That was false. That was not verified. So that's the problem. So you need to have that human observation over there. So you handle it, you use it, but you need to be first, you become AI user expert. And why I'm saying this, because you need to know what kind of prompts you want to enter in this machine to get the result. And that is a very new skill set these days people are talking about. So you need to know what kind of
Pratish, sorry to interrupt you. My question was just, from a practical point of view. A journalist goes, I told you, to go and cover a news, and then he or she comes back. How does he or she use AI tool? For example, I'll tell you, we had a doctor here saying that we are now into pain management, we are into this and we are into that, of course. And the journalist would go there and cover this particular news, comes back to the newsroom. Now tell me a situation where he or she comes back to the newsroom, and how does AI come into the picture?
Exactly, I was talking about this only, sir. If I have gone somewhere to report something, I have some information about it, I'll come back and I'll use my system, giving the prompts that this happened at that place, this was the time, this was the place, and this was the outcome. Please create a story for me. It will create a story for you. But it can create certain paragraphs which are not in context or not verified.
So you have to come in.
Yeah. So at that time, you need to have the sense, yet if you have gone to cover that story, you can easily rewrite the story for your use. If you are assign that story to someone who has no idea about it, he will not be able to write the story or edit the story. That's the problem. So human overview or human insight is very important. AI is there to help you, not to give you the 100% support what you require.
Now, one area where probably AI is becoming easier would be, these days, journalists would always say, in my time, of course, we had to go and physically cover something, but now these days, journalists would tell the organization, just at the end of the day, please send me a press release, or tell me what you have to say, and the press release is sent. And they would be very specific that you send a soft copy, so that you just can edit the press release. Now, he or she would get a press release, and then use AI to rewrite that press release. Is it correct?
See, actually it's happening. It's happening. So, I mean, see, AI can help you, give you that kind of press release, whatever you need. But you need to understand that is not the original content. You are giving the prompts, you are giving the information, then using those information, AI is creating that.
No, here in this case, they're not using the prompt at all. They're using the entire press release to rewrite it.
It can rewrite.
That can rewrite.
Obviously, I mean, if you go to Gemini and you ask them to create one copy, it actually creates 3 copies. Draft 1, Draft 2, and Draft 3. It's for you to go through all the drafts and decide what drafts are good for you, or you can rewrite taking the information from all 3 drafts.
But you don't see in the future that health journalists will become redundant?
It's very, very important question, because obviously writing is the core of journalism. If you know how to write, you are a journalist. I mean, it's my opinion. And at that point, the machine is helping you to create a very good write-up, filled with good words and good adjectives, and everything is there. But again, nobody will read a good copy without the content, without the verified content. I asked one question from Gemini months back, because as a fact checker, I used to go and give the fact checking session as well. So I asked that all your answers you are giving, are all these answers verified and fact checked? The machine says no. It's your job to identify and observe and fact check all the content I am generating. So they are, other thing is that there's a copyright issue. There is a copyright claim can happen if you are creating, the machine is creating content for you and you are using somewhere. That can be a case of copyright claim. That can be a case of digital piracy thing also. Because the machine is creating the content on the basis of the data they have. And how many of you are using Gemini or Bard? Anyone? I mean, so many people must be using. So I'll give you a tip here. Whatever questions you are putting in the machine, after some day you can see your questions in Google search. With your name or without your name, I don't know. But all the questions and answers Google will use, putting all those question and answer in their Google search. So it's a case of privacy also. So whatever you are asking, whatever questions you are asking, whatever answers you are getting from there, whatever using in your professional work like health writing is a very, very important and critical work. So it's very important to understand all these kind of things. This is going to create a problem if you don't. I mean, AI literacy is the first thing we need to go for that before using AI tools.
Yeah, that's valid. Now, Dalip, you mentioned in your presentation that ultimately AI uses the background information that's already available, collates it, and then probably puts out a rewritten or a remodeled version. Now, obviously, AI is taking material from various sources. Now, AI may be able to rewrite these materials, but ultimately, idea is also copyrighted. So do you think you will run into a legal issue if somebody finds out that you have stolen an idea and incorporated into the, you can use a mic.
Yeah.
Yeah.
So the question is regarding the content or idea in what sense?
In content, and see, you generate a story, there will be two parts of it. You plagiarize the content of it. You physically lift paragraphs and put it, or rewrite it slightly here and there. But there is also one aspect where you take an idea, for example, a exclusive story that's written. Obviously, this will be on the social platform or the media platform. So from there, if you take an idea also, and AI uses this idea in some form or the other, does it come under copyright?
So right now, I think that area is a bit gray. There is no clear answer to that, because the way today, if you get something from ChatGPT, you put it on Gemini or you put it on any other platform and say that, is this plagiarized? It will say, no, it is not. Okay.
But you will not say the idea is plagiarized.
Even if you put that.
Okay.
So the area is very, very gray right now, and that's why most of the, if you say, as I was saying, all the countries are right now trying to see where AI really ends and where the real human part of it exist, and there is confusion between that, and that's why it is very, very important for all the governments to look at and say that, okay, this is what is allowed and this is what is not allowed, because today it is pulling from so many different sources and learning from so many different sources. It's almost like my kid going to a school and maybe from class 1 to 10, he picks up one line from each poem and then puts it in front of me saying, see Papa, I have written another poem. You will not be able to tell if this is a poem that he has got from somewhere else or he's doing, because the way it is evolving, especially now with Gemini, the latest version that has come, it's so evolved that it is able to mask all those things that you are worrying about. It's if you put it on any other platform, it will not be able to identify if it is plagiarized or not.
I had asked for you, I wanted to ask for you, as you said, in India you have a couple of newspapers using AI, for example, Times of India, Odisha, somebody using. And what are the typical stories that they have been using?
So most of the places what we have seen, they are summarizing the articles. They are not really creating, or even if they are creating, they are not giving, as I said, it's like a diabetes kind of a thing, wherein you don't want the world to know that I am using it so much. Maybe Pratyush is a better person to answer that if the people are doing that completely 100% articles being written by AI itself. But most of the search that I have done, it's summarizing the articles, or maybe where very staccato kind of a communication need to go out, like weather report, where you don't have anyone
Yeah.
questioning you, saying that, okay, it was 37 and 36, it doesn't really matter so much. But in larger context, if they are using it completely, I'm not too sure.
And by the time I finish asking a question to Pratyush, I would like you to re-bring your slide on the 10 points, because you ran through it to be informative to the journalists. So if you could bring that across on the screen.
Sure.
Pratyush, I wanted to ask you something. Now, ultimately, AI depends on a lot of the information available out there in the platforms, various platforms. So do you see in future, could there be a situation where there are, say, people or hackers or people who try to disrupt the system by writing stories that may look genuine but is not genuine? And ultimately, you know the famous case of that particular pianist who was a German-Oriental who came to Goa, and ultimately it was a hacker's job. So can hackers write stories that look original and put it on the social media, and probably AI would pick up from there, and ultimately we'll all land in a soup?
If that story is there on internet, it's on platform, available to everyone, there's a chance that the machine could pick that story as genuine piece. There is a chance. So the lot of discussions are happening on this front that you raised, sir. We need to understand, I mean, the difference. If I am a writer, so earlier what I was doing, that I was going to Google and search from the keywords, and I'm getting some details. And all the details I'm searching in Google search, that is coming with the source. That I know that this part is taken from this URL and this URL published by that person or this organization. In Gemini, what is happening, there is no source. There's absolutely no source. So if I am picking some part of some information from Gemini, I have no idea about it. And that can put me in a problem. If I am using it for my professional purpose.
Yes.
If I am using for my personal purpose, this is fine. If I am writing some blog, which is fine. But if I am writing a story, which is going to be published by many media houses, that's a problem. So my suggestion is that if you are writing you are doing some professional work or some research work for a very critical topic, I mean, you can take help from the machine, but it's very, very, dicey case it will happen if we blindly believe on the content which is being generated by this machine. But again, this will help you. As you mentioned, sir, there is a possibility, because Gemini and Gemini and ChatGPT are the two main tools right now. There are a lot of tools are there. Hundreds of tools are there, paid version and unpaid version. Paid version are giving great examples of story writing, because you never know what is the source. So, and there is a high chance that I just said that if you are searching something in Gemini, that content is going to come in Google search at some part of time. So whenever you go to Gemini and if you are using, just do one thing, just go to the setting and change the setting to don't save my question answer in your system. Then it will save for 3 or 4 days only, then it will delete. But
can there be an anti-Gemini system, in the sense that Gemini writes a story, and anti-Gemini writes another story which is counter, and then you do not know which is genuine?
That's why I said that AI literacy is very important before going to AI to use it for professional work.
I'll ask you a blunt question, Pratyush. You are in PTI. If your rules of disclosure does not prohibit you, does PTI use AI?
It's like PTI is completely based on spot news, and it's creating spot stories.
But even for spot news, you need background.
Background definitely, but you cannot believe.
Believe the background, yes.
I just gave an example that it gave me a background which was false. So I cannot go blindly on that. I'll definitely go for the source of the data, and after verifying that source only, then I'll use in my story. Otherwise, I will not.
Yeah, so ultimately you need a human interface where you need to cross-check the facts.
Absolutely.
So the general rule is that you don't believe AI completely, and you're all safe, in the sense that journalists are still needed. Probably journalists are more needed now, because you need to cross-check what Gemini is telling you. So I think we are professional, not be on threatened or something like that. But then I'll leave for you to explain the 10 steps that AI adoption in newsroom. Before that, of course, you answered that question. Yeah, 10 steps here.
Yep, I think, yes, I think these are, and just one last thing, I think if you really want a more referenced kind of data, Bing is a better one, the one that is from Microsoft. It gives you the references, so you can always go and check. Other two don't provide you any references, they give you just very plain text, and then this is your responsibility to really go and check whatever you want to. So this is the one that I found. I think this was a report that I was going through a few days back, and I found it interesting, and I thought I'll share it with you all. It talks about the 10 steps that you need to keep in mind. First is to identify tasks that can be aided by an AI tool. Within your whole newsroom, where do you want?
Quickly
Do
run
you
through
want
it so that
for-
quickly run through it so that we can
Sure,
ask
sure,
questions,
sure.
yeah.
Map out your new operation cycle and where an AI tool might fit in. Like I was saying, when people are talking about summarizing the whole thing, people are talking about getting a snapshot of a news. Pinpoint the category of tools you will be considering, because there are huge categories that are available. Consult the AI tools database and establish performance benchmark. Shortlist 3 to 5 potential AI tools. Select 1 or 2, and then clearly outline what you want. Set up your newsroom for success. Understand the life cycle, and also understand when do you want to really retire an AI tool. So these are like 10 steps, and it very clearly says that by step 2 you should be clear what kind of AI tools you want, and by 6 and 7, if you're not very clear where you want to go, then you should hold on. And as I think Pratyush was also saying, that you should not get into something because it is talk of the town. That was all from my side. Thank you.
So ultimately, any questions from the media on AI? Because you are, yes, sir, yes, I expected you to stand first because AI told me that you would be the first to ask questioner.
My concern and question is already answered, but still I repeat my concern.
Please.
I am a health writer, and they say I am a very good content writer also.
Is AI telling you that, or
So
people?
when you were speaking, I was intimidated. And I was to ask you, will this AI will kill me? Or you have some consoling words for me that no, AI will not kill you. You can use AI, but that is.
So I think it's a very common thing that people keep talking about, and today, because I come from advertising agency, my background is that people say, will advertising agencies die, right? And I think someone summarized it very well, that AI will not take your job, but someone who understands AI will take your job. So I think AI has become so important that we will have to understand. It's like smartphone. I think a few years back, people said that I don't need smartphone, I'm never going to learn it. But today you see an 80-year-old man and a 3-year-old kid, all of them are using it, and it has become part and parcel of their life. So we will sooner or later understand that it's going to stay here, and we'll have to learn how to live with it.
Yeah, quickly, Pratyush, you wanted to answer?
Sir, I'll assure you that AI is not going to kill you. That is 100%.
Long live
Because you
Dhananjay.
know how to write. AI doesn't know how. AI knows how to write, but AI doesn't know what to write, and you know what to write. That's the important thing. Thank you.
Thank you very much. We're running short of time. I think it was a very interesting session. We could have gone on AI. And thank you very much, Nadeep, Pratyush. Please stay on because we need to give you a memento.
May I request Mr. Rajiv Tikku to please come forward? Mr. Rajiv Tikku, editor, consulting editor, Outlook. ग्रुप फोटो खिंचा लो। Can we have a group photo, please? Okay. Thank you for your patience. It's been a long day. So now we are moving on to the awards and felicitation ceremony. For this, I would like to invite our special guest on the dais. First of all, Dr. Chandrakant S. Pandav, Padma Shri Awardee, former HOD Department of Community Medicine, AIIMS, New Delhi, President ICC IGD, Iodine Man of India. Sir, if you can please join us on dais. Dr. Rajiv Gautam, President Horiba. Sir, if you can please join us on dais. Dr. Sushil Kumar Vimal, Director, National Urban Health Mission. Sir, if you can please join us. Mr. Sudhir Mishra, Managing Partner, Trust Legal Law Firm. Mr. R. Shankar, President, HEAL Foundation. Mr. Rajiv Tikku, Consulting Editor, Outlook. Mr. Manish Rastogi, Founder, Health Continuum. So Dr. KP Kocher, HOD Department of Physiology, will also AIIMS, New Delhi, would also be joining us shortly. Dr. Subhash Giri, Director, Lady Harding Medical College. Sir.
So we'll take 5 minutes to reveal a coffee table book we have been, HEAL Foundation has been working on for almost 6 months now, and it's a very interesting topic that is on our Prime Minister Narendra Modi ji, the healthcare change maker of the century. So this has been thoroughly researched for about 6 months led by Mr. Shaili Vishwajit ji, a very popular author, along with me, and the complete research team which has been working in the back end. And we have got a lot of inputs and compilations as well as quotes from top experts of the country, medical, healthcare experts. So we'll just run a 2-minute video on that and reveal that coffee table book quickly before we start the award. And then after that, we have almost 50 health media from across the country who have flown in with us, including the top Indian publications from the different cities and the leading healthcare influencers, YouTubers and Insta influencers. They have been patiently waiting for a long time. They had a long day catching a flight in the morning and then staying with us. This is the last moment. We'll just try to finish everything in next 45 minutes, then push on for a special dinner organized for all these 50 guests in the hotel, a cocktail dinner organized for them where they can relax. So we'll just start with the video first.
This has been totally envisioned by Dr. Swadeep Srivastava. This was his and of course guided by our President Raj Shankar, written by me, and it's led by a team of senior researchers, academicians. See, we are going very fast simply because it's been a long day. But basically, I'll tell you, let the slides go on. The whole rationale was, a lot of things has been written about Modi ji, and a lot of things have been, but health arena was one aspect where we felt there was a vacuum, and a lot of things needed to be documented, and in an authentic manner, not in a very superficial manner, but in a way also which is easier to read for today's audience, but with authentic concept, authentic content, research and all that. So the whole idea was conceived, let's have an easy to read format in a coffee table book manner, but with total authenticity and endorsement by world's and India's leading medical fraternities, policy makers and other things. So you will see each chapter has one or two endorsements like Dr. Wali Padam Shri, Dr. Kochar. You will see each chapter, different chapters, Dr. Narendra Saini, former General Secretary IMA, Dr. Kishan Chugh. You know, there are people, there are diplomats, there are bureaucrats who have endorsed and verified what we had to say. And as we went ahead with our research and writing, we really realized that Narendra Modi has put Indian healthcare into a futuristic mode and with a compassionate touch, which has not been done before. That's why we thought, and with so many incentives, you know, that will bear fruit in the times to come. That's why we felt, Dr. Srivastava felt, R. Shankarji felt, that yes, he actually the healthcare change maker of the century. And that's why this book, I hope you will appreciate it. Thank you.
Thank you, Shaliji. And
yeah,
we will release the copies of the book in the next 1 month, but we'll just do a formal release for limited copies. I request all the dignitaries to come in the front, please.
Sir, 3 copies.
We'll just start with that.
we will be running the ceremony in the alphabetic order. First of all, I'll request Dr. Akhil Kumar Sharma, Professor, Department of Cardiology at King George Medical University, Lucknow. If he's here, please come on the stage, please. Dr. Atul Kumar Shrivastava, Senior Consultant, Surgical Oncology at Dharamshila Narayana Hospital, Vasundhara Enclave. Dr. Deni Gupta, Senior Consultant, Medical Oncology at Dharamshila Narayana, Vasundhara Enclave. Dr. Dheeraj Gautam, Director of Histopathology at Medanta, the Medicity, Gurugram. Dr. Nagendra S. Chauhan, Director Cardiology at Medanta, the Medicity, Gurugram. Dr. Nikhil Mahajan, Interventional Cardiologist at Shri Mata Vaishno Devi Narayana Multispecialty Hospital, Jammu. Dr. Vijay Kumar, Director Interventional Cardiology at Fortis Escorts Heart Institute, New Delhi. Dr. Gaurav Mahajan, Director and Head Cardiothoracic Vascular Surgery at Dharamshila Narayana Hospital, Vasundhara Enclave. Dr. Yasir S. Rizvi, Associate Director and Senior Consultant, Nephrology and Kidney Transplant at Dharamshila Narayana Hospital. Yes, please. Mr. Ajay Sehgal, Senior Manager and Head Media Relation at Sir Gangaram Hospital. Mr. Biswajit Das, Editor, Health and Senior Principal Correspondent at Bharatman. Mr. Nitendra Singh, Senior Correspondent at DD News. Mr. Shahid Akhtar, Editor at The Economic Times Online Healthcare. Mr. Vishwanath Pilla, Assistant Editor at The Economic Times. Mr. Vivek Shukla, columnist at Navbharat Times Online. Dr. Akhil Kumar Sharma, Professor, Department of Cardiology at King George Medical University, Lucknow. I'm repeating the names if I have missed anyone. Dr. Akhil Kumar Sharma, Professor, Department of Cardiology at King George. Dr. Atul Kumar Shrivastava, Senior Consultant, Surgical Oncology, Dharamshila. Dr. Deni Gupta, Senior Consultant, Medical Oncology. Dr. Dheeraj Gautam, Director of Histopathology. Dr. Nagendra S. Chauhan, Director of Cardiology at Medanta. Dr. Nikhil Mahajan, Interventional Cardiologist at Shri Mata Vaishno Devi Narayana Multispeciality Hospital. Dr. Gaurav Mahajan, Director and Head Cardiothoracic Vascular Surgery at Dharamshila Narayana. Dr. Yasir S. Rizvi, Associate Director. Mr. Ajay Sehgal, Mr. Biswajit Das, Editor, Health and Senior Principal Correspondent, Mr. Nitendra Singh, Mr. Shahid Akhtar, Mr. Vishwanath Pilla, and Mr. Vivek Shukla. So I have moving on to Under 45 Healthcare Changemaker Awards. Can I have the video, please? We are just joined by Dr. Nagendra Singh Chauhan, Director Cardiology at Medanta, the Medicity. He has been the Jury's Choice Award. And Dr. Vijay Kumar, Director International Cardiology at Fortis Escort Heart Institute, New Delhi. Jury's Choice. And Dr. Gaurav Mahajan, Director and Head, Cardiothoracic Vascular Surgery, Dharamshila Narayana. So now moving on to under 45, Miss Akriti Bajaj, Senior AVP at Invest India. Mr. Arvind Pahwa, General Manager, Sales and Marketing at Fortis Memorial Research Institute, Gurgaon. Mr. Bidan Chaudhary, Founder of Taka Healthcare. Dr. Chavi Gupta, Senior Consultant, Infectious Disease at Yashodha Super Speciality Hospital, Kaushambi. Dr. Neha Rastogi, Senior Consultant, Infectious Disease at Fortis Shalimar Bagh. Dr. Nikhil Modi, Senior Consultant, Pulmonology, Respiratory at Apollo Hospital, Indraprastha. Dr. Nimarjit Kaur Rajpal, Founder, Satnam Herbals. Dr. Pankaj Raina, Lead Medical Affairs, MDS India, Becton Dickinson. Dr. Shubhank Singh, Vice President, Delhi Medical and Dental Society. Dr. Suman Karant, Senior Consultant, Medical Oncology, Fortis Cancer Institute, Gurgaon. Dr. Harleen Oberoi, Surgeon, Aesthetician and Social Media Influencer. Dr. Imran S. Patel, Founder, Asian Children Hospital and Pediatric Influencer and YouTuber. Dr. Prashant Warrior, Co-Founder and CEO, Cure.ai. Dr. Shilpa Jaiswal, Associate Consultant, Neurology at Fortis Hospital, Gurgaon. Dr. Tanya Bakshi, Director, Baxen Group. Dr. Tanu Anand, Scientist, Indian Council of Medical Research. Dr. Priyanka Rohatgi, Chief Nutritionist at Apollo Hospital. Ms. Mekhla Bavse, Influencer, Entrepreneur and Digital Content Creator. Mr. Naveen Uppal, Digital Marketing and Branding Expert, Fortis Healthcare, Gurgaon. Dr. Robin Khosa, Senior Consultant, Radiation Oncology at Apollo Cancer Center, Delhi. Mr. Rohit Singh, Managing Director at Feedback Medical India Private Limited. Okay. Mrs. Saloni Anand, Co-Founder at Traya Health. Dr. Sandeep Katiyar, Consultant and International Pulmonologist at Apollo Hospital, Kanpur. Dr. Sneha Kumari, Assistant Professor, Vardhman Mahavir Medical College and Safdarjung Hospital. Last but not the least, Dr. Soumya Tandon, Assistant Consultant, Psychiatry at Sir Gangaram Hospital. So I would be repeating the name once again so I don't miss any. Ms. Akriti Bajaj, Senior AVP at Invest India. Mr. Arvind Pahwa, General Manager, Sales and Marketing, FMRI Gurgaon. Mr. Bidan Chaudhary, Founder, Taka Healthcare. Dr. Chavi Gupta, Senior Consultant, Infectious Diseases at Yashodha Super Speciality Hospital, Kaushambi. Dr. Neha Rastogi, Senior Consultant, Infectious Diseases at Fortis Shalimar Bagh. Dr. Nikhil Modi, Senior Consultant, Pulmonology, Respiratory at Apollo Hospital, Indraprastha. Dr. Nimrajit Kaur Rajpal, Founder, Satnam Herbals. Dr. Pankaj Raina, Lead Medical Affairs, MDS India, Becton Dickinson. Dr. Shubhang Singh, Vice President, Delhi Medical and Dental Association, Dr. Suman Askaran, Senior Consultant, Medical Oncology, Fortis Cancer Institute, Dr. Harleen Oberoi, Surgeon, Aesthetician and Social Media Influencer, Dr. Imran S. Patel, Founder, Asian Children Hospital, Dr. Prashant Warrior, Co-Founder and CEO, Cure.ai, Dr. Shilpa Jaiswal, Associate Consultant, Neurology, Fortis Hospital, Dr. Tanya Bakshi, Director, Baxen Group, Dr. Tanu Anand, Scientist, ICMR, Dr. Priyanka Rohatgi, Chief Nutritionist, Apollo Hospital, Ms. Mekla Basse, Influencer, Mr. Naveen Uppal, Digital Marketing and Branding Expert, Fortis, Dr. Robin Khosa, Senior Consultant, Mr. Rohit Singh, Managing Director at Feedback Medical, Mrs. Saloni Anand, Co-Founder at Traya Health, Dr. Sandeep Katiyar, Consultant and Interventional Pulmonologist at Apollo Hospital, Kanpur, Dr. Sneha Kumari, Assistant Professor, Vardhan Mahavir Medical College, Dr. Soumya Tandon, Assistant Consultant, Psychiatry at Sir Gangaram Hospital. Moving on with the felicitation of our media friends who has traveled from different parts of country to attend this program. I'll start with Mr. Shahid Akhtar, Editor, ET Health World. Ms. Ramanshi Mishra, Reporter Fellow. We are also joined by Dr. K.P. Kocher, Professor and HOD, Department of Physiology, AIIMS, New Delhi. Ma'am, please.
Apologies for being
Please, ma'am.
There were some other things going on.
Ms. Ramanshi Mishra. Mr. Atul Kumar Singh, Resident Editor, Swadesh. Ms. Shizan Nazmi, Principal Correspondent, Times of India. Mr. Pavan Kumar, Input Head, Dainik Jagran. Ms. Shizan Nazmi. Shizan Nazmi. Shizan Nazmi. Mr. Pavan Kumar. Mr. Ranjan Kumar, Principal Correspondent, Hindustan. Mr. Ranjan Kumar. Ms. Ranju Abhimanyu, Digital Head, Prabhat Khabar. Mr. Shantanu Ghosh, Deputy Principal Correspondent, ABP. Mr. Prithvijit Mitra, Assistant Metro Editor, Times of India. Mr. Biswajit Das, Editor Health, Bartman. Mr. Biswajit Das. Okay. Mr. Kshirod Dipti Bhattacharya, Special Correspondent, Sambad Pratidin. Mr. Shubhendu Mehti, Special Representative, The Statesman. Mr. Dinesh Paliwal, Health Reporter, Dainik Bhaskar. Yes, please. Mr. Dinesh Paliwal. नहीं है. Mr. Javed Khan, Health Reporter, Dainik Navjyoti. Ms. Shamim Khan, Health Reporter. Ms. Pranita Bhardwaj, Chief Sub-Editor, Dainik Bhaskar. Ms. Pranita Bhardwaj. Mr. Vivek Shukla, Health Editor. Ms. Donita Jose, Senior Digital Content Creator, Times of India. Mr. Bandari Maheshwar Rao, Senior Journalist, Namaste Telangana. Mr. Nomula Sri Sailam, Assistant Chief Reporter, Sakshi Telugu Daily. Mr. Machala Dinesh, Sub-Editor, Deccan Chronicle. Mr. Azam Khan, Health Writer, Andhra Prabha. Ms. Taruni Gandhi, Principal Correspondent, The Sunday Guardian. Mr. Arul P., Principal Correspondent, Deccan Chronicle. Mr. Sachikanta Nath, Chief Sub-Editor, Sambad. Mr. Manash Panda, DGM News, Samay. Mr. Dhritiman Ray, Special Correspondent, Times of India. Mr. Hemanta Kumar Pradhan, Principal Correspondent, Times of India. Mr. Mukut Das, Senior Correspondent, Times of India. Ms. Samantha SP, Senior Correspondent, Silicon India Magazine. I would request all the awardees to please wait for a group photograph. We will have a group photograph after we have given all the awards. Request all of you to please be seated till then. Thank you. Change your- Mr. Nomula Sri Sailam, Assistant Chief Reporter Sakshi. Mr. Dinesh Macharla, Sub-Editor, Deccan Chronicle. ये हो गया. Mr. Anand Kumar Tiwari, Senior Medical Reporter, Prabhat Khabar. Dr. Mekhla Bavse, Dentist, Fashion and Travel Influencer. Mix है ये. Yes. अगर गलत हो गया किसी का तो चेंज कर दो. Sometimes I'm repeating the names so that no one misses. Dr. Mekhla Baswe, Dentist, Fashion and Travel Influencer. Ms. Chaitra Narendra, Fitness Influencer. Dr. Rashi Agarwal, Mental Health Influencer. Ms. Simrat Kathuria, Nutritionist and Holistic Health Coach. Dr. Dimple Jangda, Ayurveda and Gut Health Coach. Dr. Umesh Wadhwani, Nutrition and Women Health Specialist. Dr. Dimple. Dr. Dimple. Please. Dr. Simrat Kathuria. Dr. Dimple Jangda. Okay. Dr. Umesh Wadhwani. Miss Medhavi, Lifestyle, Beauty and Mental Health Influencer. Miss Medhavi. Okay.
Please.
Dr. Prateek Makwana, Consultant, Embryologist and Health Influencer. To all awardees, I'll request again to please stay back for group photo.
All the awardees will request to please stay back for the group photo. All the awardees, please.
Mr. Digvijay Singh, Nutritionist, Health Influencer. Mr. Abbas Haider, Assistant Programming Head, Red FM. Please. Mr. Digvijay Singh, Nutritionist, Health Influencer. Mr. Abbas Haider. Mr. Saurabh Kanaujia, producer Big FM. Mr. Saurabh. Mr. Prabhu Jha, Vice President and National Head, Government and Political Vertical Radio Mirchi. Ms. Meenakshi Jha, Development Communication Expert. Dr. Harleen Oberoi. Now I would request all the awardees to please come on the stage, and the media friends and influencers, all of you please come on the stage for a group photographs. Request all the awardees, under 45 Healthcare Changemaker Award, Jury's Choice Healthcare Changemaker Award, and media friends to please come on the stage for a group photo. बोलो तो क्यों नहीं आया? मैं तो नाम लिया था, नाम लिया था मैंने. Request all awardees, media friends and influencers please come on stage for the group photo. Ansh, can you please check if anyone is outside who has won the award for the group photo, please?
Yes, yes.
Request all awardees to please come on stage.
आगे बैठ जाते हैं.
I also request all media friends to please come on the stage. I can see a few of them sitting. If you can please join us on the stage. Before we close today's program, we will be presenting our token of appreciation to all our dignitaries. Token of appreciation to all the dignitaries. I request all my friends to please leave the stage and please take your seats while we present our token of appreciation to our dignitaries. Request all of you to please wait for this ceremony. I humbly request all of you to please wait for this ceremony while we present token of appreciation to our guests. At first, I will request Dr. Swadeep to present our token of appreciation to Dr. K.P. Kocher, Professor HOD.
ऐसे मत करो यार, ऐसे सीधी लाइन लगाओ ना, ऐसे ही बोलना है. आगे आगे कर दीजिए.
अच्छा है फोटो.
आप इधर आओ. बोले हैदराबाद टीम.
We are just present the mementos to you. You have been a wonderful audience. Request you to please bear with us for next 5-10 minutes. Please take your seats. So as a token of appreciation to Dr. K.P. Kocher, Professor HOD, Department of Physiology, AIIMS, New Delhi, Dr. Swadeep will present a token of appreciation from HEAL Foundation. Dr. Sushil Kumar Vimal, Deputy Commissioner, NUHM, Government of India. Dr. Sushil Kumar Vimal, sir. Dr. Subhash Giri, Director, Lady Harding Medical College. Dr. Rajiv Gautam, President Horiba. Dr. Rajiv Gautam. Mr. Rajiv Tikku, Consulting Editor, Outlook. Dr. Pandav, sir. Yeah. And Sudhir Mishra ji hai? Sudhir Mishra ji hai? Manish Rastogi. Mr. Manish Rastogi, Founder, Health Continuum. Thank you. Thank you. Please have tea. We have tea outside.
Manish ji.
Sir.
Thank you so much, everyone, and thanks for your patience, thanks for your time. Thank you to all the health media, all the health influencers. I would request to join us for tea outside. And there's a dinner for all our guests, for all the health media and all the influencers. At the hotel, we have a cocktail dinner waiting for them. So please, we have a transport outside where you can we'll take you through the transport to the hotel and have a relaxing time there at the hotel. We'll see you there, meet you there at the hotel. Thank you so much. Requesting all the faculty and the special guests also to please join us for the dinner at the hotel. At the hotel at around 8 p.m. we'll start the cocktail dinner. Thank you.
Dr. Harleen, if you can please join us on stage. Dr. Harleen Oberoi, surgeon, aesthetician, and social media influencer. Dr. Harleen Oberoi. घुमा लीजिए वार्ड को। Thank you.
इस पल को मुमकिन करने के लिए आदित्य ने पहले से ही शुरुआत कर दी थी।
ये पल सच हुआ ये पल, गिन गिन के पुनके सजा है ये पल, बरसों से जुड़ के बुना है ये पल, सौ ख्वाब मिलके बना है ये पल, आंखें कभी नम कर जाता ये पल, ये पल सच हुआ ये पल।
और म्यूचुअल फंड से शुरुआत करना जिम्मेदारी की निशानी है।
म्यूचुअल फंड
बैकड्रॉप लगा दो, बैकड्रॉप हमारा वाला वीडियो लगा दो, इंट्रो वाला।
Namaskar, I am Dr. Swadeep Srivastav, representing HEAL Foundation and the HEAL Health Group. Today it is my privilege to host
बैकड्रॉप चेंज कर दो। Thank you everyone. You have been a wonderful audience. The high tea would be outside the auditorium. Please join us for the high tea.
Namaskar, I am Dr. Swadeep Srivastav, representing HEAL Foundation and the HEAL Health Group. Today it is my privilege to host all the real storytellers of the country at this largest 8th National Health Writers and Influencers Convention. And we also have the privilege to host you at the most prestigious institute in healthcare, that is at AIIMS, All India Institute of Medical Sciences, New Delhi. So I would like to start with a small introduction of our journey, which we started 20 years back to give a shape to storytelling in healthcare in the form of Health Writers Engagement Program, wherein we created a platform of HEAL Foundation. I remember about 2 decades back when we started this journey, and the idea was to create a healthcare information ecosystem in the country which is more responsible, which is more effective. And for that, one of the most important stakeholders we all realize were the health media, health writers, who are today now they are in the form of new age media influencers too. And we started this journey about 2 decades back with HEAL Foundation program called Health Essayists and Authors League to train and to do the capacity building of health media of the country. And we have traveled a long journey from starting with 1 workshop to about 400 workshops what we have done with health media, and 7 national conventions which we are very proud of conducting successfully, engaging and training and sensitizing and motivating about more than 1,000 health media in this journey of 2 decades, and engaging with more than 300 key opinion leaders, experts from all sort of specialties and expertise in healthcare.